I'll start. Yes. So, hello students, a very good morning and a happy Independence Day. On that note, we will begin today the last leg of the NEET PG 2026 preparation in pediatrics. So, let's begin. Today, I have divided this class into the various questions which have come in the previous NEET, and I have clubbed them into various topics. So that let's revise a little bit on the topic and then let's solve the MCQs and let's complete as much of pediatrics, which is the high yield section in NEET, as soon as possible. So with that, we'll begin with one of the most important sections, that is growth. So what is growth? Growth is a quantitative increase in size. It is measured by very specific parameters: weight, height, head circumference, mid-upper arm circumference, skin fold thickness, and body mass index. This is then compared with standard values. Now, when we say standard values, it is essentially the growth charts. Which growth charts? The standard followed are the WHO growth charts. And then the growth is assessed based upon where the child falls in various charts. Another important section where questions are asked is the device used. So, how is length measured? Remember, length is always measured less than 2 years of age. Less than 2 years is length. Above 2 years is height. Height is always above 2 years of age. Now, just a quick revision. Why is it like that? This is because the children have very soft heel pad of fat. Even though a child can stand from as early as 9 to 10 months, we check only length, because when the heel pad of fat is compressed, the child will look smaller and shorter than what he actually is. So that is why length lying down is measured using an infantometer till 2 years of age. Height above 2 years measured using a stadiometer, not a standing measuring tape. Okay. A standing scale. None of these are the correct answers. They are all given as options. Standing scale, vertical scale, all of them are wrong. Head circumference and mid-upper arm circumference, both measured using a non-stretchable measuring tape. The options have also been written as measuring tape and non-stretchable measuring tape, viscous material measuring tape. These all were the questions which I've seen. Now this viscosity, stretch and all are not there. They're all wrong answers. The correct answer is non-stretchable measuring tape. Skin fold thickness, Harpenden calipers. Now this is how you measure using the infantometer and stadiometer. The infantometer, the child is lying down. There is one fixed side and there's a mobile side. The child's vertex is always approximated to the fixed side, and the mobile side, when the child is completely flat with the knee stretched, knee is not bent, with the knee stretched, the mobile side is then approximated to the vertical foot. The foot is not this way, the foot is vertical. Once that has happened, the child is lifted, and then on top of the infantometer, you can see the length of the child. Okay. Now, stadiometer, this is simple. There is a moving kind of a parameter which is on top, and the child is made to stand with the feet flat, the heel of the foot, the buttocks, the shoulder blade and the occiput are in contact with the vertical side of the stadiometer. The eyes are level in what is called the Frankfurt's plane. The Frankfurt's plane is where the eyes are completely at level and the eye gaze is parallel to the ground. Okay. So this plane is kept, and then the mobile part of the stadiometer is brought down to the vertex. Then the child stands off and the height is checked. Now coming to the pathological growth. Short stature, very important, very high yield. Height is called short stature when it is below the 3rd centile. Remember, the options will be 1st centile, 3rd centile, 10th centile to confuse you, because small for gestational age comes as 10th centile for weight. So this is 3rd centile or -2 standard deviation. This is very important. Okay. -2 standard deviations below the mean height for the same age and gender. Now, let's see what should be the average heights. At birth, a 3 kg baby will weigh 50 centimeters. By 1 year, there should be a 15 centimeter increase, sorry, a 25 centimeter increase in height, and half of that, a 12 centimeter increase in head circumference. Okay, so height is 25 centimeters and the head circumference will increase by 12 centimeters. By 2 years, an average height will be something like 90 centimeters, and by 4 years, 100 centimeters. So, approximately, they will ask you by what age does the child double in height? It is 4 years of age. And by 12 years, a child average height child is around 150 centimeters. Now remember, this depends upon what the height of the parents are and whether it's a girl child or a boy child, because girl childs attain puberty fast. So the girl child may be a little taller by 12 years, whereas the boy child may appear a little shorter. So this is very average, the 150 centimeters. Now coming to short stature. Short stature, two types: proportionate, disproportionate. Proportionate means this section, if you look at the picture here, the upper segment. Now, what is the upper segment? This is measured by the pubic symphysis. Vertex to pubic symphysis and pubic symphysis to floor. So, vertex to pubic symphysis is the upper segment, pubic symphysis to floor is lower segment. Always the child's height is taken and then the subtraction is of the lower segment. We never subtract the upper segment because it's very difficult and not accurate to measure till the pubic symphysis. So, there is no measurement of upper segment. It is height minus lower segment equal to upper segment. Now, this ratio is taken. The ratio is taken to see which part of the body grows how. So, if upper segment, lower segment ratio is normal, what is normal? See the box below. In a newborn, the upper segment, lower segment ratio will be 1.7 to 1.9:1. The upper segment is bigger, the feet and the limbs are smaller. As the child grows, the upper segment grows at a slower rate, the limbs grow faster. So, by 3 years, the ratio comes to 1.5:1. By 5 years, this ratio is 1.3:1 by 5 years. And by 7 to 10 years, 1:1 to 0.9:1. This is the upper segment, lower segment ratio. Now, if this ratio is altered, then it is called disproportionate short stature. If it is maintained, it is called proportionate short stature at whatever age of the child, because this decides our various causes. Let's see our next slide. I will go further. Okay. Now, how do you differentiate between the various causes of short stature? We have familial short stature, constitutional delay in growth. This is called CDGP or growth potential, hypothyroidism, and growth hormone deficiency. All these were the commonest causes. Now, in this, all of these are equal to proportionate short stature. All are proportionate short stature. There is no abnormality where the upper limbs are growing or the lower limbs are growing and the body is not growing, or vice versa. Okay. So let's go over quickly. The familial short stature, they are always short. They are born to short parents. Everybody is short in the family. The puberty is normal. Clinical examination, development, everything normal. Body is proportionate short stature. Height, velocity, puberty, everything normal. Bone age will be equal to chronological age always, but the height age will be a little less. So, chronological age equal to bone age, which is greater than height age, because they are short stature. Okay. Nothing to do, they belong well into that family. Constitutional delay in growth potential. Here, the child appears to be a big baby at birth and then starts to seem small as the child reaches 4 or 5 years of age. Child looks a little short. Now, here the parents will be very worried as to why the child is small when in their family everybody is normal height. But however, if you ask history, the parents also would have had this small growth in the first early childhood of the parents. Okay. Puberty can be delayed in constitutional delay because the whole growth is a little delayed. When we say growth, it is not only growth, it is even the pubertal development is a little delayed. Everything will get a slightly more delayed, but never pathologically delayed. We'll come to puberty also. Apart from that, everything normal. If you plot the graph, the child will be on the lower growth curves, but height will be gaining properly. And here, the bone age and the height age will match. because the height will be a little small and the growth also is a little delayed. So bone age and height age will match and both will be less than the chronological age. Okay. So nothing to do, like how the parents suddenly shot up height during puberty, this child also will shoot up height during puberty. Coming to hypothyroidism and growth hormone deficiency. Now here we have actual pathology going on. Hypothyroidism also short, the birth weight may be big, may be normal. Otherwise, child is okay. Development can be delayed. They'll have coarse features, features of cretinism if not identified early. Here, the body proportion can be disproportionate, but it is not always. I have seen children who have proportionate growth delay with hypothyroidism also. So, the number of children who have disproportionate short stature are a small number called the Cocker-Debris Semi-Lange syndrome. Those children are a small group of hypothyroid children who have disproportionate short stature. Okay, the majority group of congenital hypothyroidism do not have, they have proportionate short stature. So this is only in the Cocker-Debris Semi-Lange syndrome. Here height is also delayed. Here bone age will be delayed, height age will be delayed, everything will be less than the chronological age. Okay, here it has to be identified, has to be treated. Now, growth hormone deficiency. Now, here the child is going to be born normal and then growth will be very, very significantly delayed in growth hormone deficiency. Very much more compared to all the other types. Okay. Development will be normal. Puberty will be delayed in these two. The child will remain very short, like constitutional dwarfism. It is not achondroplasic dwarfism, it is constitutional dwarfism where the patient is actually very, very small. Here also chronological age will be the most highest number. The height age, the bone age, everything will be grossly delayed. This can be treated well if diagnosed early with growth hormone. Now coming to the next important parameter, head circumference. Remember this, no matter how much I underline the importance of this in an MCQ, it is very, very important. This comes as problem solving MCQs and this also comes as a recall MCQ. So let's do both. This is most important. The first 3 months, 2 centimeter per month. Next 3 months, that is from the 4, 5, 6th month, 1 centimeter per month. Next 6 months till 1 year of age, 6 to 12 months, 0.5 centimeter per month. So if you look at these three, you have an average of 12 centimeter per year. Remember, height was 25 centimeters in the first year. Okay, first year of life. Next 2 years, this sometimes have seen asked, so I put it here. Between 1 to 3 years, the increase in head circumference is as much as 0.2 centimeter per month, but this is better plotted on charts. Microcephaly, macrocephaly, very high yield. Remember, microcephaly is more, -3 standard deviation. Macrocephaly is -2 standard deviation. Okay. The way we used to remember, just to be sure, is that micro is MI and macro is MA. A comes before I in the alphabet. So this is -3 standard deviation. This is -2 standard deviation because A is coming ahead. This is a short way to remember. Okay. So -3 standard deviation, age and gender. Causes of microcephaly, very, very important. Chromosomal disorders. Anencephaly. Anencephaly, I would not put as a major issue, but yeah, textbook wise it is there. Craniosynostosis, this is called acquired microcephaly. Another condition, where do you see acquired microcephaly? Rett syndrome. Okay, that is, sorry, both of these are acquired microcephaly. Angelman syndrome. If you have teratogenic drug intake, maternal diabetes, toxemia, that is PIH, IUI, birth asphyxia where the brain is not growing, etc. Macrocephaly, remember the problem will be 3 with the bone, with the brain, with the fluid. With the bone, you have osteopetrosis and rickets where the bone is having an issue. Even thalassemia, where the bone is having an issue, you will have that frontal bossing and macrocephalic appearance. Even in achondroplasia dwarf, macrocephaly because the bone is thicker. Okay. In brain issues, we have megalencephaly, any structural malformations in the brain which are going to cause a lot of metabolite accumulation, which are the neurometabolic disorders, and fluid increase, which is hydrocephalus, hygroma, etc., sudden massive hematoma, ventricular dilatation following intraventricular bleeds. All these are causes of macrocephaly. Now, mid upper arm circumference measured by Shakir's tape. Shakir's tape is what gives you the 3 colors. Okay. Age group you measure is between 6 months and 5 years. Now, the zone based upon the color and what measurement you see, 11.5 is the cutoff. Anything below 11.5 is severe malnutrition, SAM definition, everything comes here. Between 11.5 to 12.5 borderline, above 12.5 normal. So that's how the Shakir's tape is made. Growth charts, what do? They graphically represent the anthropometric parameters. This was also a strange recall MCQ which I saw in a much older paper. The WHO growth charts represent 1 Z-score, 2 graphically represent anthropometric parameters like this. So it was a very simple question but just worded around English. Only till 5 years of age, and they graphically represent the anthropometric parameters. You have the girls, you have the boys charts. Okay. Now let's do a quick revision of the questions that came in growth. What is the most reliable sign to assess adequate growth in an infant with a birth weight of 2.8 kg? This came in 3 years back, NEET PG. Is it weight under 75th centile, height under 25th centile, anterior fontanelle closure by 6 months of age, weight gain of 300 grams per month till 1 year, or increase in length of 25 centimeters in the first year? If for those who have been listening, I think there's no doubt on this. The correct answer is D. Weight under 75th, height under 25th is definitely wrong, because weight under 75th, height under 25th, above 10th and above 3rd is normal. Anterior fontanelle closure by 6 months of age is worrisome, because this means it is either developing some acquired microcephaly or the brain is not growing. Weight 100 grams of 300 grams per month? No, 300 grams per day, 300 grams per month is never recorded. Just to do a quick thing for you, weight gain 30 to 35 gram per day first 3 months. Okay, 20 gram per day next 3 months, 15 gram per day the next 3, 12 gram per day last 3 months. Similarly, let's check the height. Height, if just remember it like this, it was at 35, no? 3 to 3.5 centimeter per month. This weight is in days, okay? In the first 3 months, 2 centimeter per month for next 3 months, 1.5 centimeter per month for the next 6 to 9 months, and 1.2 centimeter per month for the last 3 months. Okay, so this is just a quick revision for you. Okay. Next question. The growth curves in the image represent different patterns of growth for various organs or systems. Which represents what? This is 2 years back NEET. Okay. Now, you look carefully at what is written there and you see the various curves. Okay. Now, you have this one curve where the curve is going and going up suddenly, shooting up suddenly. Now, shooting up suddenly, you can see this, going straight, sudden height is there. Now, this is obviously going to be because pubertal height, this is basic, all of you know it. So, this is the somatic growth because puberty happened. Okay. Now, how did the brain grow? The brain grew, it grew first in the first 2 years and then stabilized. That looks like the first curve. So, this is the brain growth. Now, which organ of the body grows and regresses? They are the lymphoid growth. So, this is the lymphoid growth. Okay. And which organ grows parallelly nearly with the pubertal growth? That is the genital growth. So, which fits? Now, 1 is brain. Yes, we wrote that. 2 is Waldeyer ring. That is the lymphoid growth. Yes. 3 is somatic growth. We wrote that. And 4 is testicular growth. We wrote that. So, here 1 is automatically the right answer. The correct answer is A. The liver, spleen and all, don't take it into account. Those all should automatically go out. You should have this doubt, this option between 1, 2, 3 only. Okay. Next question. A 16-month-old child weighs 8 kg. Very, very, very low, less. Okay. Based on the provided growth chart, what is the most appropriate advice for the child? Now, here it looks very small, but I'm sure on in the actual paper it will be able to be seen much better. Now, if you look, this is 10, okay, 9, 8. Now, this is 16-month-old. This is 1 year. 1 year, 1 month, 2 month, 3 month, 4 months. So, this will be somewhere here. Okay, 8 kg here is coming at this point. Okay, it's coming at this point. Okay, now at that point, what do you say? It is not coming into severe acute malnutrition. Okay, it is coming just above severe acute malnutrition, but in malnutrition nevertheless. So that is why the answer for this will be moderate malnutrition. Moderate malnutrition, what are you going to do? You're going to teach the mother how to feed. If it is coming below the last line, if it was here, then you will refer to Nutrition Rehabilitation Center. This is not mild. Mild malnutrition should have come just above this charts. Okay. And this is not no malnutrition. Next question. 3 growth charts of female children were plotted on this IAP chart. WHO IAP, both very similarly coinciding. Which of these signals growth failure? Again, 2 years back NEET. Now, this is so simple that I don't even have to kind of explain this to you, I think. When do you say growth failure? You say growth failure when the child falls 2 standard lines, growth lines below. As long as a child is going alongside or parallel, child is falling parallel to growth curves, it is normal growth, or growth is growing, the child is growing. The minute the child falls or falls below or cuts 2 growth lines, cuts means, suppose you have, you saw the WHO growth charts, no? You go like this, like this, like this, you have many charts. So in that, you've been plotting the growth of the child. Suddenly, the growth tends to falter, stabilize, plateau, and it falls below 2 growth lines or normal growth curves, then you have to evaluate for failure to gain weight or failure to thrive. Now, in a 16, in this small children, failure to thrive is very important, typically below 5 years. Above 5 years, it's failure to gain weight. So, in this child, we are finding that there's only one child's chart which is cutting 2 growth curves. This child's growth weight seems to have come down. There is weight loss. Even a plateau which cuts. Now, suppose you look at this child, if it goes like this and cuts 2 growth curves, that also is going to come under needs evaluation. So, here it's very obvious. It's only number 3 child whose weight has come down. That child needs to be evaluated and suggests growth failure. So, with that, we finish growth. Next high yield topic, nutrition, malnutrition and fluid therapy. Quick revision. Malnutrition. What is the best indicator of malnutrition? The best indicator of acute malnutrition is wasting. What is the best indicator to attend wasting? Decreased weight for height. Okay. Now, best indicator of chronic malnutrition. What is the best indicator? Stunting. How do you test stunting? How do you check it? Decreased height for age. What is common to both acute and chronic malnutrition is weight for age. Because height for age is only in chronic. Weight for age, after that only, no, you calculate weight for height. So, weight for age is common to both the definitions in acute and chronic malnutrition. Now, the WHO growth charts are best charts for under 5 children, and they graphically represent the anthropometric parameters. They are sequenced for age and gender. Okay. Now, WHO classification. What is malnutrition? You have undernutrition, moderate and severe. If you have edema, it is severe undernutrition because it suggests kwashiorkor. If weight for height is between 2 to 3 standard deviation, it is moderate wasting. And if it is less than 3 standard deviation, it is severe wasting. If height for age, if there is stunting and this is between 2 to 3 standard deviation, it is moderate stunting. Anything less than 3 is severe stunting. Okay. Now, severe acute malnutrition in children who are between the 6 to 60 months of age, 59 months of age. How do you define SAM? If weight or height or weight for length, length or height is less than the third minus 3 Z score. Using that, you have the Z score WHO charts. So if it's below the minus 3 Z score, or if there's presence of edema of nutritional origin, which means you're ruling out other causes like nephrotic syndrome and hepatic dysfunction and all, or cardiac dysfunction, or if the mid-upper arm circumference is less than 11.5 centimeters. Any of these is defined as SAM. Okay. Now, SAM is very important, divided into two, with complications, without complications. With complications is when you have features of Kwashiorkor with it, because Kwashiorkor is the worst form of SAM when compared to marasmus. Marasmus still stable compared to Kwashiorkor. Kwashiorkor becomes sick very easily. And if you have bilateral pitting edema, if you have mid-upper arm less than 11, and the pitting edema, which means the upper limbs are thin and the lower limbs are edematous, which means this is marasmic Kwashiorkor. Very, very poor outcomes unless you identified it early. If mid-upper arm circumference is less than 11 and there is pitting edema, grade 1, grade 2 with anorexia, LRTI, severe pallor, high fever, dehydration or apathetic, very dull child, which means electrolyte disturbance, hypoglycemia, etc. All this is SAM with complications. Emergency resuscitative efforts to be started. Remember, SAM was resuscitative, then rehabilitative, then convalescence. No? So, resuscitative efforts to be started at SAM with complications. Without complications is the what our definition was, where the weight for height was less, upper arm circumference was less, the pitting edema was there, and child is otherwise stable, vital stable, not critically ill, appetite is good, and child feels hungry to eat, which means this comes under little bit more marasmus, not much of Kwashiorkor. Okay. And upper arm circumference is below 11.5 per se, but above 11. This we can manage in outpatient department also. Now, just the differences. Kwashiorkor and marasmus difference is that the age of onset is more than 1 year in Kwashiorkor, less than 1 year in marasmus. This is completely theoretical. Predominant in these are both called protein energy malnutrition. So, protein part more deficient than energy part is Kwashiorkor. Energy part more deficient than protein is marasmus. Edema is there in Kwashiorkor because the protein is the hypoalbuminemia which maintains the plasma oncotic pressure. Marasmus, essentially both are very much less, so there is no edema. Here you have moon face, edema, bulging abdomen, apathetic, cranky, irritable, dull child. Thin, brittle hair, monkey or old man, that's a simian, monkey or old man face, skin and bones appearance, buttock folds all are lost, all that is wasting. That is marasmus. And dull child, Kwashiorkor, apathetic, mental features are more. This is the CNS features are more in Kwashiorkor, less in marasmus. Appetite, early marasmus, you will have a decently fair, hungry, thirsty baby who is ready to eat when you give them. Once you go into marasmus, Kwashiorkor or complications, you will not have. Kwashiorkor from upfront itself, the child is not ready to eat. Prognosis, when we say prognosis, it is untreated. How soon can the child deteriorate? Kwashiorkor is faster. Now, severe acute malnutrition, what are the complications we did? Just a quick mnemonic, shielded. S is sugar deficiency, which is essentially the edema of Kwashiorkor. H is hypothermia because they don't have fat to maintain their subcutaneous pad of fat to maintain their body temperature. I is infections. EL, simple electrolyte deficiencies and imbalances. The last D is deficiencies. So automatically what does the previous D become? It becomes dehydration. Okay. This is the shielded mnemonic for SAM. Just complications of SAM. So I'm sure most of you will be able to identify, if you look at each organ system, you'll be able to identify the complications. Now, what are the other, this is the CNS manifestations, apathy, skin lesions. Now, this skin lesion is called pavement dermatosis or flaky paint dermatosis. This is typically seen in kwashiorkor, though we can also see it in marasmus. I have seen it predominantly in kwashiorkor children, this flaky paint or pavement dermatosis. What is refeeding syndrome? It started on a high calorie diet where once you start the child on nutritional rehabilitation with high calories, sudden spurt of glucose is there in the blood. Now, these children have a normal pancreas. Okay, so pancreas are normal. So when the glucose spurts, the insulin comes. So when the insulin comes, the insulin not only converts the glucose into fat and helps in formation of glycogen. Yes, all that happens. But along with that, there's a shift of metabolites and electrolytes. So there's an intracellular shift of potassium, magnesium, and phosphate. So what happens? You could just remember potassium, magnesium, phosphate. So very simple to identify what happens in refeeding syndrome. You have hypophosphatemia, magnesium, yes, hypomagnesemia, and the worrisome complication of hypokalemia. Now, this is where we are worried because hypokalemia can cause paralytic ileus. Paralytic ileus causes bacteria, they cause transmigration and result in intestinal and bloodstream sepsis. Okay, next. And your phosphate and magnesium are responsible for muscle strength, hypocalcemia. Every of these can result in respiratory failure and poor muscle potentials. Okay. Next question which came in this was, a child's height for age is below 2 standard deviation. What's the most likely cause? Very simple. All of you should be able to tell. When we discuss height for age, what is this? This is stunting. Stunting is seen where? Always in chronic malnutrition. Okay, stunting is nothing to do with acute, stunting is chronic malnutrition. So the correct answer is obviously D. Moving to fluid therapy. Fluid requirement in children is decided by the formula, which is very similar to the Holiday-Segar formula. Okay, the Holiday-Segar formula is for the calories. Yes, so the Holiday and Segar formula for calorie calculation. Very similar calculation is for fluid therapy. 0 to 10 kgs, it is 100 ml per kg. 10 to 20 kgs, it is the first 10 kg plus whatever kgs above that. The first 10 kg ke liye 1000 ml and 50 ml per kg for the next. So by 20 kg, the child should be 1500 ml. By 20 to 30 kg, for the first 20 kg, it is the 1500 ml plus 20 ml for every kg above that. So if it is 25 kg, it is 20 into 500, so 1600 ml. So remember, this cannot go on and on. That is why I put this up, that there is a maximum calculation. We cannot calculate for 60 kg children, go on and on and give 5 liters fluid. No. So the maximum is 2.3 to 2.4 liters per day. We cannot overload children. Okay. Now this is the infusion rate per hour because you divide it by the per whole day calculation. So I'll just give you a short example. You have a 10 kg child. So you have 1000 ml per day is the fluid. So 1000 divided by 24, 25 will be around 4.2 ml per hour. Okay, not per, okay, per kg. That's the short way of doing it is 4 ml per kg. Okay, another short formula for infusion rate per hour is 40 ml plus 2 ml into weight minus 10. Basically, you're just going to be using the previous calculation and then going further. Okay, so 100 ml per kg, if you have to infuse it per hour, it will come to 4 ml per kg. If you're going to give, like suppose you have to give 10 kg child, you will give it at 40 ml per hour. Calculation is ml per kg. Now for the same 12 kg child, for the first 10 kgs, it is 40 ml plus say 14 kgs, no, 4 more. So 2 ml into 4, 8 ml. So you will get 48 ml per hour. Okay, so like this calculation, quick calculation for infusion rates per hour. Please remember this because this is asked. Otherwise, the another way of doing it is by calculating the fluid and dividing it by 24. Okay, so you want to calculate like how I did, no, 1000 ml per day divided by 24, you will get something like 4.2 ml. That you will get the answer. Quick way is this way to remember. Okay, and for 20 to 30 kg, 60 ml plus 1 ml per kg for every weight above 20. And effectively, maximum we are looking at is 100 ml per hour. Choice of fluid. Now, choice of fluid, when we want to give fluid, the choice is usually plasma light with 5% dextrose. For bolus, resuscitation, dehydration, 0.9% saline. Otherwise, in children whom you don't want to overload sodium, like the smaller children, 1 to 2 years of age, it is half normal saline with 5% dextrose and 20 milliequivalents per liter of potassium chloride. Now, this is the fluid of choice. Plasma light has all these electrolytes already maintained, so we have not written the exact percentage, whereas half normal saline will be half the concentration, that is 0.45% NS, okay, with 5% dextrose and potassium chloride, okay. Now, coming to dehydration. Very high yield, very, very important. Almost always I have seen one question from this. Somewhere or the other in NEET or INIYCT, somewhere you get these questions, okay. So, what is mild, moderate and severe? Mild is where the child is irritable, thirsty, everything is normal. There's a very minimum decrease, less than 5% decrease in the body weight because of the fluid loss. Capillary refill is fast, less than 2 to 3 seconds. Very little decrease in urine output, otherwise child is okay. Antirefontanil, eyes, tongue, skin turgor, breathing, pulse, all normal. In moderate dehydration, it's a 6 to 9% decrease in body weight. Here, the antirefontanil in smaller children may be depressed. The eyes appear slightly sunken. The tongue is dry. The skin pinch goes back, but a little slowly. It is not very slowly. Skin pinch goes back little slowly. And the child may have a little fast heart rate. Breathing may be a little fast. Capillary refill is between 3 to 4 seconds. Urine output is decreased. Okay, this is moderate dehydration, the best time to intervene. Once you go to severe dehydration, complications are more. Here, mentation is affected. Child is drowsy, may be unconscious, unresponsive, very significant reduction in body weight. More than 10% of body weight is lost, very, very significant. Anterior fontanelle is severely depressed, eyes are deeply sunken, the mouth is very dry, the tongue is furred. Furred means the papillae are visible and the tongue is very dry. Skin turgor is very cold. The tenting, when we say tenting, it is skin pinch goes back very slowly. Okay, skin pinch goes back very slowly, or it gets stuck like that only, like a tent. That is tenting. Breathing is rapid, heart rate distinct tachycardia, capillary refill is more than 4 seconds. You may have oliguria or anuria. Now, how much is the fluid loss when you have mild or no dehydration? That time you have 50 ml per kg and less than that is lost. Some dehydration you have 50 to 100 ml per kg and severe is more than 100 ml per kg. WHO plan, very important. Plan A for dehydration. Plan A is where you have no dehydration, mild, all those conditions. So here, less than 2 years, 50 to 100 ml after every loose stool. 2 to 10 years, 100 to 200 ml. And this is essentially ORS or equivalent home-based fluids if child is not taking ORS. And above 10 years, ad libitum, how much ever the child needs. Plan B is very important. Now, this is for moderate dehydration here or some dehydration. Okay. Now, here you are going to give ORS either orally or through nasogastric tube based upon how the child accepts the ORS. The amount is 75 ml per kg ORS in first 4 hours. Now, here also oral rehydration is the treatment of choice. Okay, not IV, oral rehydration. What is the plan B? You identify some dehydration, start giving 75 ml per kg of ORS. Now, in a 10 kg child, 750 ml given over the first 4 hours. Okay. So, you will give it over 4 hours and see the child is taking. The child is taking but not ready to take happily. Child is having features of nausea. That time you will put your nasogastric tube and give the oral rehydration over 4 hours. After 4 hours, reassess. Child is better, move to plan A. Go to home-based fluids, food, and start giving after each loose stool. If the child is worsening, move on further and go to the next plan. Okay. Plan C is severe dehydration, always IV fluids. Very common question asked is, which is the fluid of choice in children with severe dehydration? Fluid of choice is ringer lactate with 5% dextrose. Okay. Yes, for bolus we do use normal saline. We can use plain ringer lactate if you don't have the 5% dextrose fluid. Okay. Now amount in children less than 1 year of age, you will give 30 ml per kg in the first hour and 70 ml per kg in the next 5 hours. The total is for 6 hours. In above 1 year, 30 ml per kg in 30 minutes, and the rest you will give over the half the time in 2.5 hours. Okay. All this is very, very high yield. Zinc is important. Zinc supplementation is what improves diarrhea. So very much asked question. Less than 6 months, 20 mg per day. Usually we have syrups which are 1 ml 20 mg. So 1 ml per day you will get, and more than 6 months, less than 6 months you will give 10 mg per day, and more than 6 months it is 20 mg per day. So children, small children 0.5 ml a day, and older children 1 ml, which is 20 mg. Now this was very similar. I saw many questions on dehydration, all very similar to this. So I just put up one. A child has a history of loose stools with increased frequency for the last 4 days. On examination, child is drowsy, not feeding. Skin when pinched, return to normal position very slowly. So according to IMNCI, where would you classify? I taught you all of this. Drowsy, CNS is affected only in severe dehydration. This very slowly is only severe dehydration. Okay. Now coming to puberty. Now puberty, I didn't find many questions, but yeah, it is a very high yield topic, and you should know puberty because this delayed puberty, precocious puberty, all are questions which do come. I have seen one in much earlier NEET, which is why I put it up here so that we cover everything in toto. Now what is puberty? Puberty is the attainment of maturity from the child to the adult. Okay. Basically, it translates to genital growth. So the growth spurt that occurs in puberty, there is an increase in height. Very commonly asked, how much is the increase in height? The increase in height is more in boys than in girls. How do you remember? In boys, the increase in height is somewhere around 20 to 30 centimeters throughout puberty. Okay. And in girls, the increase in height is somewhere between 15 to 30. In the MCQ, I saw it was between 16 to 28 centimeters throughout puberty. Okay. What are the sequence stages? Who gives the stages? The stages are by Tanner stages. All of you know the Tanner stages. 5 stages. Okay. Prepubertal in each one. In Thilarch, in Pubarch, in testicular enlargement, penile enlargement, every one of these you have seen the Tanner staging. Okay. In girls, how does the puberty begin? Puberty begins with Thilarch. After Thilarch, there is Pubarch. Okay. After Pubarch, there is a growth spurt, and it culminates with menarche. Okay. In boys, however, it starts with testicular enlargement, proceeds to penile enlargement. After that, you have the pubic hair growth followed by growth spurt. After growth spurt, what do you have? You have axillary hair and facial hair. Okay. So the growth spurt is a little later in boys as compared to girls. The pubic hair and the growth spurt and the axillary hair occur together with the change in the voice of the boy. Okay. Disorders of puberty, important, as is congenital adrenal hyperplasia. Okay, that will come to. Now, disorders of puberty. Definition: when is it precocious? Precocious is before appearance of secondary sexual characters. Okay, please don't consider as menarche. Appearance of Thilarch, even Thilarch before 8 years, and appearance of testicular enlargement before 9 years in boys is precocious puberty. Okay. Most common type is usually the central precocious. Peripheral precocious puberty is not so commonly seen at all. So what do you see in central precocious? It is puberty driven. That is, it is brain driven. That is gonadotropin dependent. Okay. And that is why it is called true precocity. It occurs more commonly in girls than boys. So in girls, if it occurs, we are considered idiopathic. In boys, if it occurs, watch out for CNS pathology. Treatment is to overwhelm the gonadotropin. So we are going to give the gonadotropin agonists. So this concept is not clearly understood by many students, where when there is gonadotropin, why are we giving more? This is to prevent the negative, the feedback inhibition which is occurring. No, we are trying to stimulate that. And the more the gonadotropin is going to be used up in the peripheral organs, the more it will be secreted. The more it's secreted, the more we'll go towards puberty. That's the basic ideology. Okay. Now, in peripheral precocity, it is isosexual or heterosexual, depends upon what type of precocity it is. This is gonadotropin independent, which means the brain and the puberty and the pubertal growth do not drive this. The hormone secreting organs are in the peripheral organs, genital organs, or otherwise outside them. Here it is more common in boys than in girls. In boys, it's typically congenital lateral hyperplasia. Why? Because in girls, congenital lateral hyperplasia is identified very much earlier at birth with virilized genitalia. In boys, this virilization is considered normal. So that is why boys with CAH get missed and come with precocious puberty in the boy. In girls, the cause can be an ovarian cause, much lesser as compared to boys. Now, other spectrum, delayed puberty. In boys, delayed puberty is if there is no testicular enlargement by 14 years of age. Okay. In girls, if there is no breast bud, no thylarch by 13 years, or no menarche by 16 years, or they have put a new clause which says that less than 5 years. So, if there is no menarche within 5 years of thylarch, we have to consider delayed puberty, where thylarch started, but however, there was no menarche even 5 years from the onset of thylarchy. So, that is also considered delayed puberty in girls. And delayed puberty is more common in boys. Nowadays, we're seeing precocity more in girls, delayed more in boys. Now, the most common cause is constitutional delay. Systemic diseases like psychological diseases, anorexia nervosa, gluten enteropathy, hypogonadotropic hypogonadism, now where the gonadotropin itself is not there. So you have low FSH, low LH, CNS causes, the absent cella, empty cella, all these syndromes, hypothyroidism, and syndromes with gonadotropin deficiency. All these are the central driven delayed puberty, okay, where the center is not producing gonadotropins, so the peripheral organs do not attain puberty. You have a condition where the peripheral organ is faulty, the center is producing a lot of gonadotropin, but peripheral organ is not functioning. That is secondary causes of delayed puberty. They are hypergonadotropic hypogonadism. Their FSH LH will be high, but however, syndromes where there are Turner syndrome, Noonan syndrome, Klinefelter syndrome, gonadal disorders, vanishing testis syndrome, so many of these syndromes are there. All of the testicular feminization, all these are conditions where gonadotropin will be there. However, it will not translate to puberty because the peripheral organ is faulty. So, we have done this quick revision. Topic 3, development. Okay. Focus carefully. Development is very high yield. Guarantee 1 or 2 questions from development will be there. 4 domains: gross motor, fine motor, personal, social, language. I'll go real fast on this because I'm assuming this to be a rapid revision. 3 months, neck holding, lift head. 6 months, roll over. Start sitting with support of hand. This sitting when the child may not attain by himself. You make the child sit, the child keeps its hand in front of them, called the tripod position, and the child is able to maintain a balance. 9 months, child starts sitting without support as well as start standing with support and crawling. Crawling is abdomen on the ground. Okay. By 12 months, the child stands without support, walks with support. Walks means holds and walks, holds hands and walks. Creeping, where the child is crawling with abdomen off the ground. Okay. Now, these are all I've given you the upper limits. Okay. The child starts creeping only by 9 months. Child starts crawling, pulling the abdomen by 7 months. Okay. 15 months, walks comfortably, stands on knees. Okay, stands on knees. 18 months, running. 2 years, up, down. Stairs, 2 feet per step. These are stairs without railing. Child is jumping. By 3 years, all the three things happen. Tricycle climbs upstairs with 1 foot, downstairs with 2 feet per step. So total is 1 up plus 2 down, 3. Tricycle plus climbing stairs, 1 plus 2. Able to apart from this, the child is also able to run, play simple games, run behind a ball, all these things. 4 years, hops on 1 foot, walks downstairs, 1 1. Or what they say, alternating feet. 1 foot up, 1 foot down. So alternating feet is 4 years. Okay. Fine motor. First fine motor milestone. What is it? Regularly asked. First fine motor milestone. This was asked in 2 ways. First fine motor milestone as noticed by mother. Answer is bidextrous reach at 4 months. First fine motor milestone which is appearing in the child, which should be noticed by a healthcare provider, is hands held predominantly open by 1 month. Sorry, by 1 month. Okay. So read the question carefully. What is the first fine motor milestone to be noted at a healthcare visit? The answer will be hands held predominantly open by 1 month. What is the first fine motor milestone to be noticed by the mother? Bidextrous reach, 4 months. By 6 months, unidextrous reach, then immature pincer. Immature pincer has 2 parts. You have the radial part and the ulnar part and the radial part. Which comes first? The radial approach, and between the radial approach and ulnar approach, which comes first? It's the radial approach. The ulnar approach comes first, then the radial approach. Okay, immature ulnar comes before radial pincer. They are the immature pincer grasps. By 12 months, mature pincer grasp. 15 months, tower of 2 cubes. 18 months, 3 cubes. 2 years, 6 cubes. 3 years, 9 cubes. By 4 years, child is able to make a gate, bridge. Okay, all that you all know. Okay, and by 5 years, there was a 4.5, 5 years, there was a steam engine. Okay. Then there's a hand drawing skills. By able to hold with pincer grasp by around 1 year, 115 months, the holding of pencil and crayon. Scribbles randomly by 18 months. By 2 years, horizontal vertical strokes. By 3 years, able to make a circle or a closed shape. By 4 years, able to make a cross. By 5 years, triangle. By 6 years, a kite, a rhomboid like shape. By 8 years, child is able to make a cross. By 12 years, by 8 years, child is also able to make a cylinder. By cube, by 11 to 12 years of age. Okay. Now, remember, all these are copied, not trained children. Okay. Social language milestones. 2 months, smiles at a human face. Okay. 3 months, recognizes mother. 6 months, stranger anxiety. 9 months, bye-bye. 12 months, simple ball game. 2 years, copies household chores, asks for food, able to be trained, dry by day, able to be trained for dry by night, shows toys to people. By 3 years, they know their name and gender. By 4 years, group play. Okay. By 2 years, it is called plays alone. By in language milestones, 8 weeks. Okay, so 8 weeks is vocalization. 8 weeks vocalization. 6 months monosyllables, 9 months bisyllables, 12 months 1 to 2 words, understands the meaning of no. By 18 months speaks 8 to 10 words. By 2 years, 2-word phrases. 2-word phrases. By 3 years, says their name, gender, knows their school name and all things like that. By 4 years, able to tell short story and poems. Okay. Neonatal reflexes, very important, should know as a part of development. I put it. Neonatal reflex, Morrow's reflex, disappears by 2 to 3 months. Okay. Grasp reflex, when should it disappear? You know that every time you touch, the child will grasp. So when there is a unidextrous reach coming, grasp reflex should disappear. Unidextrous reach starts appearing at 4 months. So by 2 to 3 months, grasp reflex should disappear. Rooting, sucking and all are primitive reflexes where when you touch, the baby tends to get drawn towards the mother's breast and sucking and milking. These all disappear as the child grows. Asymmetric tonic neck reflex is called the protective reflex to prevent the child from falling. The side the child turns, this is called a fencing reflex or fencing posture. Upper limb extension, lower limb extension. At the side the neck is turned, the other side is flexed. You turn this side, this hand will flex, that leg will flex, that hand and that leg will extend. That is asymmetric tonic neck reflex. Okay. Babinski's reflex. Now this Babinski, I don't think it was there in books, so I put it, but it is an abnormal sign. It's extensor plantar. Physiologically, extensor plantar occurs because of lack of myelination. This is below 1 year of age. Stepping, placing reflexes, all these are reflexes which disappear when the child starts standing and crawling. So they disappear by 5 to 6 months of age. Neonatal reflexes that after birth persist for life. Neck right reflex called the Landau reflex and the parachute reflex. Now, abnormal development, very commonly asked. Rett syndrome. Here, the child has started its journey normally, and then there is neuroregression with stereotypic hand wringing movements, writhing, ringing hand movements with regression of speech. So how do you remember this? Now, Rett syndrome have a lot of abnormal behavior. So the mnemonic was screams, S for seizures, okay. C, constipation, yes, very good. R is what happens in Rett syndrome. As the child starts growing more and more, they have jerky breathing. So irregular respiration. Okay. E is eating difficulties. Okay. Bruxism, poor swallowing, dysphagia, keeps food in the mouth, all these issues. A is arrhythmias, cardiac arrhythmias as the child grows older. These all risks are there. M is stereotypic movement disorders. Along with this, you'll have dystonic movements, development of scoliosis, all this happens. S is sleep disturbance, okay, where because of bruxism or abnormal laughing called gestaltic seizures, the child starts laughing a lot at night, all those are sleep disturbing. This is X-linked dominant inheritance, affects females. The mutation is called the MECP2 gene on the X chromosome. This has also been asked, please memorize this, MECP2 gene on the X chromosome. Okay. MRI brain shows generalized atrophy, generalized cerebral hemisphere atrophy. Okay. So there's no specific area, everywhere there is generalized atrophy. Okay. Then intellectual disability. In this, I just wanted to focus on the IQs. Mild intellectual disability. Now, usually anything above 80 is normal. Mild is between 51 to 80, 70 to 80. So 51 to 80 is mild. Moderate 36 to 50. Severe 21 to 35 and profound less than 20. Now coming to another high yield topic, which is breastfeeding. Okay. Similar, like development, breastfeeding has important questions. You should know it very well. Okay. When do you start breastfeeding? Within, what's the answer? 1 minute. Okay. Within the first hour, within the first hour of birth. Earlier, it used to be within 30 minutes and all. Now, we are trying to get it within 30 minutes, whether it is cesarean baby or it is a normal delivery baby. Upper limit is 1 hour of birth, irrespective of normal vaginal or C-section. Exclusive feeding according to WHO for minimum of 6 months. Complementary feeding after 6 months of age. Now, there was a question, when is the earliest you can initiate complementary feeding? Please remember very carefully. If the option says according to WHO, it is the earliest you can initiate is at 6 months only. Okay. Now, how much of the feed? Now, the lip turned outward, cheeks being full, upper part of areola not being visible, signs of good attachment, good latching, you should know. Okay. The cheek being inward, suck is visible in the cheeks are collapsed inside. The lower lip is not turned outward. The upper part of the areola and the entire areola almost is visible. Child is detaching after every 5 minutes and taking a breath. All those are signs of poor latching and congestive cardiac failure. Now, between 6 months, complementary feeding question asked was how much to feed. So, between 6 months to 1 year, please look at the infant and young child feeding guidelines. If you have a time, there's just one table. It was just too big to cut and put here, so I didn't put it. I have just written it in short. Half to 1 katori, you're going to start at 2 to 3 times a day and gradually increase from 6 months. Okay, half katori at 6 months, 2 to 3 times a day, and gradually increase it. Okay, above 1 year, 1 to 1.5 katori offered 5 times a day. Now, benefits of breastfeeding. Importance between breast milk and cow's milk, I cannot underline, that's how important is it. The protein in breast milk and cow's milk, 3 times difference, 1.1 gram per deciliter or per 100 ml, and this is 3.3 gram per 100 ml. Important proteins are lactalbumin and lactoglobulin. Cow's milk also has whey proteins. Casein, whey protein. Okay. Lipid, 4.2 gram per 100 ml. Their lipid is less, 3.8. These are brain protective stimulated fatty acids, which are polyunsaturated fatty acids and the docosahexaaminoic acid, all for brain growth. Carbohydrate, lactose is the predominant sugar in both, and it is almost nearly similar. Even in cow's milk, it is lactose only, but the human breast milk has a little bit more carbohydrate with 7.4 because there's a fore milk and hind milk difference. Okay, and cow's milk has uniform. There we can't make a fore milk, cow's milk, hind milk in cow's milk, so it is 4.8. Calcium, 35 milligram per 100 ml. Phosphorus, 15, 1:2 ratio. The calcium phosphorus ratio, whereas in cow's milk it is less than 1:2 ratio. The minerals, or especially most important mineral we're looking at is iron, which has got greater bioavailability. Very, very, very important. Iron is deficient in any milk. However, in human milk, bioavailability iron is high. Immunological superiority, why? Because you have antibodies. Which antibody you have? You have primarily IgA antibodies, though you have a small percentage of IgM also. So you have 2 antibodies secreted in the breast milk. You have predominantly IgA antibodies, some bit of IgM antibodies also secreted in breast milk. Apart from that, you have lymphocytes, lactoferrin, PABA, all other protective factors. Mental growth, greater IQ in children who are breastfed as compared to babies who are on formula feeding, though this is on the genetic potential. Bonding with mother and being able to have a good feeling of security is there in breastfed babies. There is protection against what all? There's protection against ear, GI, CNS infections, dental caries, all it protects against. Lower risk of diabetes, lower risk of obesity, better development, better neuro development. Okay, all of it is there. Okay, lower risk of acquired heart diseases is what is also said. Anti-infective substances I have discussed already. You have lysozymes, you had secretory IgA, you had macrophages, you had IgM antibodies, you had PABA, which protects against malaria, you have lactoferrin, anti-staphylococcal factor, you have what else? IgM antibodies, all of it is there. These are all the anti-infective substances. So PABA, important ones, PABA against malaria, IgA, IgM, lymphocytes, then transforming growth factor beta, then other lysozymes, all of it, anti-staphylococcal factors, all these are there. Okay. Now, when is breastfeeding contraindicated? Again, very common questions. Contraindicated typically in galactosemia. Very good. We have conditions called glucose galactose inborn error metabolism. There are also some IEMs where you cannot manage breastfeeding, where this urea cycle defect, those defects and all, where organic acidemias, where the child cannot feed that protein content in the mother's milk. In something called lactose intolerance, but this is primary lactose intolerance. Secondary lactose, you just have to stop it for a while. When the mother is on some drug therapy, which drug therapy? Chemotherapy. Okay. When the drug is on anti-thyroid drugs. Anti-thyroid drugs, typically the carbimazole and the methimazole group. Propylthiouracil is still safe. When the mother is undergoing radiotherapy or using drugs like lithium or gold salts. These are all maternal drugs which are contraindicated for babies breastfeeding. Relative contraindication is active tuberculosis, active varicella zoster infection. All these are very significant but relative contraindication. Of course, when the mother is having, say, some very significant illness because of which she can, even Crohn's disease, ulcerative colitis, these all, when the medications involved higher medications, yes, those are all for that period of the medication, we avoid breastfeeding. Okay. And next, now coming to the questions. So many questions like this, I put them all together. A breastfeeding mother has introduced thick homemade cereal as complementary food to her 7-month-old. How much should we give? How often according to the infant and young child feeding guidelines? So, what did we discuss? Between 6 months and it was half katori. So, wherever everything is half katori. Now, how many times a day? 6-month-old to 7-month-old, you're going to give, offer it 3 times a day. Okay. Start with 2 times a day, 3 times a day, 4 times a day, 5 times a day. Half katori 6 to 7 months, then 1 katori 8 to 9, 10 months a day, you start increasing. Okay. So, half katori 3 times a day is the correct answer because it is just introduced. She has just started. So, at starting it is 2 to 3 times a day. An HIV positive primary gravida, she was initiated at ART late, 34 weeks. Viral load 1200 copies per ml. Healthy term baby vaginally. She has decided to breastfeed. What is the recommended approach? Will we give nevirapine zidovudine for 12 weeks along with exclusive feeding? Will we allow mixed feeding where it's breast milk plus formula without HIV prophylaxis? Obviously, you all know that is wrong. Okay. Provide a single nevirapine dose and encourage breastfeeding. Initiate 6-week nevirapine prophylaxis with exclusive feeding. Now, the decision between A, C and D depend upon the viral load. Any viral load more than 1000 copies per ml is high viral load. She has been started ART not upfront in pregnancy, way late in pregnancy. So, this kind of situation, there are a lot of viral particles already in the baby, but we cannot test them until 6 weeks of age. So, what are you going to do? You're going to give the best possible protection. The best possible protection is nevirapine zidovudine for 12 weeks alongside exclusive breastfeeding, and then we are going to test and see. At 6 weeks of age, we will test, we will continue, then we will start oral cotrimoxazole and go further. This 6 weeks nevirapine prophylaxis would have been if this mother had a high viral load but had taken ART during pregnancy. That time, we would have perhaps given a single agent. Breastfeeding in HIV. Now, see, this is based on counseling option. Remember, okay? Counseling option. There is no contraindication. So, breastfeeding is not contraindicated in HIV. Okay, it is a contraindication as selected by the parents upon counseling. Mixed feeding is contraindicated. Mixed feeding means formula milk plus breast milk, contraindicated in HIV. Okay, so if the mother chooses to breastfeed, it is exclusive breastfeeding. If she chooses to formula feed, it's exclusive formula feeding. Okay, there is no mixing. Then if it's a breastfed child, proceed for 6 months and start complementary feeds. If she chooses formula feeding, exclusive formula feeding with breast milk suppression, and proceed for complementary feeding at 6 months. Okay. Now, Now, antiretroviral prophylaxis, see, this is what I was discussing there. The mother's not on ART, high viral load, or recently treated, it is double drug therapy for double the time. 2 drugs, 12 weeks. Low risk, mother is on ART, then the nevirapine is given for 6 weeks. There used to be nevirapine single dose for mothers who had negligible viral load and who choose to breastfeed and whose viral copies were low, but that is a little older NACO guideline. Coming to hepatitis B, baby born to HPCG mother, what is it? You are going to breastfeed. No contraindication. Okay. Composition of hepatitis B immunoglobulin, very important. You should know 0.5 ml is equal to 100 international units. How is it important? You are going to one arm. Okay. In one arm, hepatitis B vaccine, other arm or thigh, hepatitis B immunoglobulin will be given, both a 0.5 ml within 12 hours of birth. This is the hepatitis B prophylaxis or management of neonate born to HBsAg positive mother. One side hepatitis B, one side HBsAg, given within 12 hours of birth. Now, a few other neonatal topics. This will just go quick. Neonatal resuscitation, 10% of newborns do require resuscitation, very less, maybe less than 1% will require actual CPR and chest compression. You have 1 minute time to decide whether you need positive pressure ventilation. So every 30 seconds, you will renew your decision. First 30 seconds, you will give a good tactile stimulation and clear the airways. Next 30 seconds, if baby is not breathing, you will give tactile stimulation and start blow by oxygen. Before that, if baby, at 1 minute, baby is not breathing, initiating bag and mask ventilation. Okay. Very commonly asked question, I've seen it in 3 NEET papers, it is this. What is the sign of successful positive pressure ventilation? A rising heart rate is the only sign of a successful positive pressure ventilation. There is no other sign. Okay. Now, volume expansion in children who have come with dehydration and shock because of maybe massive abruption or placenta detachment, something like that, wherever, then volume expansion is given, and it is given when you have bradycardia. When you have bradycardia because of shock. Shock is because of primarily hypovolemia, and this doesn't respond to other resuscitative measures. You're going to give volume expansion. Bag and mask ventilation contraindicated in congenital diaphragmatic hernia. Okay, that is the only contraindication for bag and mask ventilation. Elective intubation has to be done. Okay, a ratio of chest compressions, remember, is 3:1. 3 positive pressure to 1 chest compression. Oh, I'm sorry, 1 positive pressure to 3 chest compression. Kangaroo mother care, another very high yield. What is kangaroo mother care? It is the caring of a small preterm low birth weight infant through skin to skin contact with the mother. Very useful in low income countries where maintenance of neonatal, of such small babies' body temperature is very affected because they don't have that warmers. So best is to use the mother's body to maintain the neonate's body temperature, because preterms, IUGRs, SGA babies all have a risk of neonatal hypothermia, which is disastrous consequences, including loss of life. So what are the components of KMC? Remember, there is semi-reclining position. Okay, now this is. Okay, semi-reclining position. Semi-reclining means 45 degrees angle. Semi-reclining position. Semi-reclining position, baby put on mother's chest, face down. Okay, the baby's chest is on the mother's chest. Okay, approximating chest to baby. Okay, chest of the baby approximates the chest of the mother. Okay, and the baby is covered. Okay, covered with baby cloths and mother's clothes. Okay, the baby cloth is put on top of the mother, and the mother's kind of a cover sheet which mother uses is covered. The baby is also covered with it. Okay, now duration, how long should we do this? Now this is done in stable neonates. Okay, there was a question saying that the baby is unstable. So what are the, all of the following can be done. A baby who is preterm, 32 weeks, on ventilator with this problems, has just been weaned off ventilator. Can this baby be started on KMC? 1, yes, it can be started on KMC. 2, yes, it can be started on KMC with monitoring. And third option was no, we cannot start. Fourth, we cannot start KMC because the baby may go back on ventilator anytime. The answer is, if a baby is, they say vitals are stable. The answer is yes, you can start KMC with monitoring. Baby is unstable on fluids, on head box oxygen or something like that. Baby is not stable, vitals required, baby is on inotropes, anything like that. Unstable babies, we cannot start KMC. Okay. Very important for 1.8 kg and less babies. It's very useful. KMC should be given only by mother? No, KMC can be given by any family caregiver who can, because in twins and triplets, it's very difficult for the mother to do everything. So KMC can be given by any family member. Even father can give KMC, even aunt, grandmother, whoever is the family member of the child can give KMC. Okay. Neonatal sepsis, it is the signs of systemic infection with or without bacteremia in the first month of life, which occurs within the first week of life. So first week is called early onset sepsis. Beyond first week till day 28 of life is called late onset sepsis in neonatology. Okay. So what is the most common etiology? In early onset sepsis, this is what is commonly asked. In early onset sepsis, you have the maternal genital flora. So you have E. coli, group B streptococcus, and then H. influenzae, listeria. These are all early onset sepsis. Late onset sepsis, this one flora gently change. You would no longer have group B streptococcus. You have E. coli as the main. You can also have other streptococcus, H. influenzae, other bacteria, Klebsiella, etc. can also be there in late onset sepsis. Okay. What is the most common manifestation of neonatal sepsis? You can have hypothermia, you can have reduced feeding, reduced activity. All of these are most common manifestations of neonatal sepsis. How do you do? If baby is small, blood culture has to be taken. Start treating with baseline like AMPI and Genta. If the baby is older, you will take blood culture. If you have a central line culture, urine culture, and if you have signs of meningitis, a CSF culture. This is not CDF, this is CSF culture. Okay. And then you begin treatment with higher antibiotics, where you're going to look at the staphylococcus and all these bacteria. Watch for cultures in 24-48 hours. If cultures are negative, de-escalate. Remember, if cultures are negative, always de-escalate antibiotics. Perinatal asphyxia, important, where child cannot initiate or sustain good breathing in the initial extrauterine life. This is the definition of perinatal asphyxia. So what should the APGAR score be to say severe asphyxia? If the APGAR score is less than 3 at 1 minute of age, it is called severe perinatal asphyxia. Severe acidosis if pH is less than 7. Very scary situation, honestly. CNS manifestations like seizures, hypotonia, especially occurring on day 1 of life. All these are suggestive of perinatal asphyxia. What do you do? What is the only therapy we have for perinatal asphyxia which is not prophylactic? That is therapeutic hypothermia. Therapeutic hypothermia is the only measure we have to prevent for treatment of this one. Rest all are preventive measures. Now, this is very, very important. Okay. A term baby has perinatal asphyxia. Which part of the brain is affected? It's the parasagittal cortex. In a preterm baby, it is the periventricular area. Because the term baby has parasagittal cortex affected and the preterm baby has periventricular area affected, that is the reason why you have different clinical features, where you have spastic quadriplegia and severe HIE in term baby, and you have spastic diplegia in HIE in a preterm baby. APGAR scoring, what is the APGAR? It's APGAR. Appearance, pulse, the grimace or the facial response to a noxious stimulus. Activity, which is the muscle rebound and tone. R is the respiration. Okay. You have 0, 1 and 2. 0 is cyanos child with no pulse, no response. When you say response, which response it is? It is response to nasal suctioning and clearance of secretions. Okay. Response to nasal suctioning, response to tactile stimulation, that is the reflex. Activity, muscle tone, where the baby is floppy, and respiration, the baby is breathing. How it is it jerky, gasping breathing, or it is strong, normal breathing with a good cry, based on that 0, 1 and 2. Total is 10. Very rarely you can get 10 because there's acrocyanosis. So the highest score is 9 by 10. Lowest score will be much lesser, and if it is less than 3 or like 0 or something, then yes, very, very severe asphyxia. Hyaline membrane disease, very commonly asked, preterm issue, surfactant deficiency. Surfactant is produced by what? Type 2 pneumocytes. Type 2 pneumocytes mature into the respiratory tract in the 3rd trimester of pregnancy later. So the earlier the baby, the lesser the migration and formation of the type 2 pneumocytes. That is by surfactant deficiency. Okay. Constituents of surfactant, this you all know. Phosphatidylglycerol is the main constituent of surfactant. Lecithin is another constituent of surfactant. Apoproteins and glycoproteins are constituents of surfactant. Now, what do you see in the chest X-ray? You will see reticulonodular opacities, ground glass appearance in severe HIE with air bronchograms. So, ground glassing with air bronchograms. Constituents for those who have phosphatidylglycerol, most important. Okay, lecithin, phosphatidylglycerol, most important constituent. Management, start with antenatal steroids. From antenatal steroids, after that, early use of CPAP, early use of positive pressure ventilation for baby so that the alveoli don't collapse, and administer surfactant. So antenatal steroid, surfactant given endotracheally. Okay, these all are the management of hyaline membrane disease. So another small things, fetal lungs develop by 20 weeks, amniotic fluid, it is tested by 28 to 32 weeks. Only above 34 weeks, 34 to 35 weeks, do you find good amount of surfactant. So babies who are born below 34, 35 weeks will always have a risk of hyaline membrane disease. So the absence of surfactant causes the lack of surface tension. So the alveoli which are open because of the breath cannot stay open and they collapse. Next, neonatal hyperbilirubinemia. Now in adults, any bilirubin more than 2 is evidenced in the eyes. Whereas in children, especially neonates, the bilirubin level should be more than 5 mg per deciliter to be even slightly visible on the face. The eyes are not an indicator for jaundice. Most common cause of jaundice on day 1, yes, tell me. This is pathological hemolysis. Pathological hemolysis is because of blood group incompatibility, which can be RH or ABO, severe ABO incompatibility. Okay. Usually, this will present within day 1. Normally, jaundice is seen only after 24 hours of life. That's called physiological jaundice. What happens if this is day 1, day 2, day 3, day 4, and this is day 7? By day 1, you don't see jaundice. By day 2, it starts, peaks, and by day 7, it starts coming down. By day 10, the jaundice has disappeared. This is physiological jaundice. Pathological jaundice is what starts anyway outside of that curve. Beyond day 10 to day 14, presence of jaundice. Below day 1, appearance of jaundice. All these are pathological. Conjugated hyperbilirubinemia is always pathological. Okay. So, icterus is seen to progress from the face downwards. This is called the Kramer's rule. Kramer's rule, where it progresses. Involvement of palms and soles means more than 15 milligram per deciliter is the jaundice in the palms and soles. Etiologies, remember it is day 1, day 2, day 3. Day 1, RH, ABO incompatibility. Day 2 to day 7, exaggerated physiological jaundice, breastfeeding jaundice. Okay. Day 4, day 5, day 6, day 7, which is more enzymopathies, where by the time the jaundice should start disappearing, day 7, day 10, there you have your Dubin-Johnson's, your Krigler-Najjar severe variants, all starts coming. By week 3, week 4, presence of jaundice is usually breast milk jaundice. Breast milk jaundice comes later. Breastfeeding jaundice comes earlier. Breastfeeding jaundice is because of inadequate feeding. Breast milk jaundice is because of very adequate feeding, but an inhibitor in the breast milk which binds to the conjugation UDP glucuronide transferase in the liver. Okay. So etiologies I have discussed, so I am not scribbling it here. Investigations for hemolysis, what are you going to do? You are going to do TB dB. Okay, to see whether it's conjugated or unconjugated. You're going to do hemoglobin peripheral smear to see for signs of hemolysis. You will do an LDH to see for signs for hemolysis. You will do a retic count to see for reticulocytosis when there's significant hemolysis. So all these are the main investigations to look for hemolysis. If you want to prove, you will do a direct Coombs test to prove that it is because of blood group incompatibility. Treatment, usually it is unconjugated. Okay, unconjugated. Unconjugated, you're going to treat with phototherapy. Blue light, 490 nanometer is the blue spectrum. Okay, so blue light is what you're going to keep the baby under when you're going to use phototherapy. This has 3 photooxidation, photoisomerization, structural isomerization to lumirubin, conversion into water soluble polymer, excretion in the urine. That is the basis of phototherapy. Metalloprotein, tin metalloprotein is used as the drug for unconjugated jaundice when it is very high. Okay, other drugs which are other treatments which we use for hemolytic jaundice, we can even use IVIG because it's an antibody dependent reaction. Then what are the other things you can use? Anti-D. In those who are blood group positive, anti-D immunoglobulin can also be used, along with, if it is very high, exchange transfusion. Exchange transfusion if it is very high. Okay. Now, to complete neonatology, just a brief, quick on the skin mucosa. This kind of reddish patches with yellow center, red wheals, erythema toxicum, normal below day 4, day 5 of birth. Eosinophilic infiltrates. This slate gray pigmentation, Mongolian spots. Now, this is because of dermal migration of melanocytes, neural migration of melanocytes. This is because of the skin and the brain developing from the ectoderm. This is Epstein pearls. These are small inclusion cysts at the junction of the hard palate and soft palate. Now, when the child is exposed to abnormal temperatures, you will have mottling of skin, that is called cutis marmorata, just because of vascular instability, nothing else. This is called a stalk bite because the hemangioma is the redness. It is not an actual hemangioma, it disappears by 2 to 3 weeks of age. Milia are these white inclusion cysts because of these are sebaceous glands whose secretions are blocked. Okay, the Epstein's pearls are inclusion cysts. Now, acne neonatorum, very rarely seen. Transient pustular neonatal melanosis, all these are rarely seen. Okay, coming to infectious diseases, measles, all of you know this. I'm just doing this real fast. Causative agent is the morbillivirus or the measles virus, which is in the paramyxoviridae. Okay, morbillivirus, paramyxoviridae, mode of spread droplet or respiratory route. Pathogenesis, it goes primary viremia, secondary viremia, lymphoid organs, you know all of this. Clinical manifestation is rash, the typical measles rash goes further down from the face, down to the neck, over the body. And then coryza, fever, and conjunctivitis. This is the classical triad of measles. Okay, diagnosis is clinical. You can test with IgM measles if you want to confirm. We do IgM measles when we have complications of measles, like measles pneumonia called Hecht's pneumonia. Hecht's is H-E-C, Hecht's pneumonia. If you have this complication, yes, we do IgM measles regularly. If you have measles with CNS complications, we do IgM measles in the CSF. Treatment, supportive. Prevention, measles, mumps, rubella vaccine. In the government, what is given is the MR vaccine, which is the measles. What is the strain? The Edmundston Zagreb strain. And yes, I forgot, Koplik spots. These are spots seen inside the next to the junction of the first and second molar. The first and second molar, there you see these white spots. Those are the Koplik spots. Mumps, you all know causative agent, mumps virus, which belongs to the rubella virus group. Okay, again, this is a paramyxoviridae. Respiratory spread, pathogenesis is the same. Clinical manifestation, you have unilateral or bilateral parotitis. Okay, with fever, myalgia, headache, and ear pain. Difficulty to chew, difficulty to eat because of the pain. Diagnosis is clinical. If you want to confirm, yes, you can do IgM mumps. Treatment supportive, prevention is through the MMR vaccine, where mumps is the ideal strain is the Gerald Lynn strain. Okay, this is the ideal strain. Oh, okay, I'm sorry. Yes, rubella, same, similar. Causative is the rubella virus, which belongs to toga viridae. Remember, this is not paramyxovirus. This is toga viridae. Mode of spread pathogenesis same. Clinical manifestations starts again with rash, fever, typical classical rubella rash, which again starts from behind the ears, go down to the body. Measles heals with a brownish desquamation, rubella doesn't. There's a difference there. There is lymphadenopathy, which is typically seen with rubella, which is not seen in others. And the rash starts from here and goes down, both in measles and in rubella. Okay, there is these Forsheimer spots, which are seen as small petechial spots seen on the hard palate somewhere close to the midline. Now, the importance with rubella is that, yes, diagnosis is also the same, clinical diagnosis. IgM rubella is not usually used. Treatment is supportive, prevention MMR. In R, it is the, sorry, R is the Vistar RA27/3 strain is what is used. Okay. MMR vaccine 0.5 ml or the MR vaccine 0.5 ml, subcutaneous live attenuated vaccine 9 months and 16 months according to the government program. Important in rubella is the congenital rubella syndrome. The most common manifestation of congenital rubella syndrome is sensory neural hearing loss. Okay, sensory neural hearing loss. The triad of congenital rubella syndrome is deafness, which is SNHL, congenital cataract, and congenital heart disease. Most common heart disease is PDA, which is more common than pulmonary stenosis, which is more common than VSD or ASD. So PDA and pulmonary stenosis most common. Clinical manifestations of congenital rubella: sensory neural hearing loss. You have intracranial calcifications. You have salt and pepper retinopathy. All this is very important. It will be asked if they want to ask on pure recall. You can have glaucoma in neonatal period itself. You have hepatosplenomegaly, liver dysfunction, growth failure, features of CCF when you have PDA and all these manifestations. You have interstitial pneumonitis. Every organ is affected. Okay, so every organ is affected. You have to look at all the organs. Okay, thrombocytopenia, anemia, bleeding dysfunction, encephalitis, meningoencephalitis. Okay, CNS with meningoencephalitis, all of it can happen with congenital rubella syndrome. How do you diagnose? Again, you diagnose clinically. And even your opthal colleagues help a lot. IgM can be done in the infant when at birth, where you suspect congenital rubella syndrome. And the risk of congenital rubella syndrome is primarily during organogenesis. That's what it shows. So 70 to 80% when it is below 11 weeks, and by 15 to 16 weeks, there is still 24%. And the frequency of infections is as seen. Chickenpox, causative agent varicella virus, mode of spread respiratory. Varicella, important something called secondary attack rate. The secondary attack rate is when one child picks up varicella from another child. This is around 90 to 95% secondary attack rate in unvaccinated population. Mode of spread respiratory droplets. Pathogenesis is where the primary viremia, secondary viremia, it's the same thing. Clinical manifestations: vesicular rash, important things I'm writing. Vesicular rash appears in crops. So you will have different rashes at different stage of maturation. Okay, that is what is very classical of varicella. Okay, then you have congenital varicella syndrome. If it occurs, less than 12 weeks of 12 weeks. Okay, less than 12 weeks of pregnancy, you have congenital varicella syndrome, multiple microcephaly, PDA, cataract changes, developmental changes in the brain, and very important thing is cicatricial skin lesions, that is scarred with contractures. Skin lesions is classical of congenital varicella syndrome. You have eye, heart, all abnormalities. Varicella, if it affects as acute varicella, which occurs between less than 5 days prior to delivery to 21 days. Sorry, just a minute. Okay, varicella which occurs in the perinatal period, which is somewhere less than 21 days to 5 days post delivery. Very, very acute, can cause acute varicella encephalitis and cause death. Okay, very, very important. Varicella you can get only in the middle trimester. You cannot get varicella first trimester or even in the late third trimester because the outcomes are very, very poor. Diagnosis is clinical. You wish to do, we can do IgM varicella, it's available. Treatment, we have acyclovir as a treatment, should be started ASAP. Another important aspect of treatment is that we have varicella zoster immunoglobulin available. So if the child is a neonate, just delivered and the mother got chickenpox, we should give immediate varicella zoster immunoglobulins to neutralize the varicella virus. Parvovirus, not so important, but yeah, erythema infectiosum causes arthropathy, myocarditis, aplastic crisis because it causes the bone marrow suppression. It causes another syndrome, which is the glove and sock syndrome, which is called the Gianotti-Crasta syndrome. Okay, so this is all parvovirus infections. Erythema infectiosum is also called the fifth disease. It's a benign self-limited exanthem of childhood. Incubation is very short, can occur as less as 4 days, and it can also go very long as 3 to 4 weeks. It has a small prodrome with malaise, fever, mild prodrome with malaise, fever. The hallmark is this slapped cheek syndrome. Slapped cheek syndrome is what you see in parvovirus infection. Okay. Infectious mononucleosis, causative agent you all know, EBV, Epstein-Barr virus. Mode of spread is respiratory, commonly saliva, not much of nasal secretions. It is saliva and other bodily fluids also. The pathogenesis is the incubating occurs in the lymphoid tissue in the Walde's ring back of the nose and then spreads to involve the other reticular endothelial organs in the primary and secondary viremic stage. Clinical manifestation starts with high grade fever, malaise, severe sore throat. I have seen children who are unable to eat and drool saliva because of Epstein-Barr virus infection, severe edema of soft palate, a lot of congestion, bleeding, petechiae, white patch on tonsil. This is a DD for white patch or membrane on tonsil, white membrane on tonsil. All these are DDs for infectious mononucleosis. We have significant cervical lymphadenopathy. This is infectious mononucleosis. If you palpate, you may even find a soft spleen. Diagnosis is made by increase in the CD8 cell count because that's the cell which fight EBV. The IgM EBV titers are most sensitive. Older tests, Paul Bunnell and monospot tests. Treatment primarily supportive. Okay. We have complications which can go like HLH, hemophagocytic lymphohistiocytosis syndrome. So to watch carefully for these complications. Hepatitis B, causative agent you all know. Hepatitis is the hepatitis B virus. Mode of spread in adults, yes, there are other modes, but in children, the most common mode of spread is the vertical route, and transfusion, blood transfusions. Okay. And here also you have the primary viremic phase where you have the acute viremia and then prolonged incubation period till it goes into a chronic active or chronic indolent stage. Okay. So you have an acute hepatitis stage where you have supportive treatment is the only option available. Then you have a chronic hepatitis B. When you have chronic hepatitis, the patient is essentially normal, but the liver shows signs of mild dysfunction, cirrhosis, etc. There you have interferon alpha 2 beta, lamivudine, adifovir, entecavir, tenofovir, all these are options. Outcomes. Now, hepatitis B. Now, we're looking at a neonate born to hepatitis B positive mother. If it is like that, then if the immunoglobulin not given, 1 to 5% may actually develop fulminant hepatitis. The majority develop into some kind of indolent subclinical infection, and they actually slowly overcome this infection. There is about a great number which can go into persistent infections, become carriers, and go into chronic hepatitis, which can develop into adolescent hepatocellular carcinomas. That also we have seen. Okay. So approximately 70% of children below 5 years of age can actually recover and develop immunity, and above 5 years of age, most of them, 95%, kind of tend to develop immunity. Now, just to wrap it up, I thought I'll put a word on the cytomegalovirus infection. It is the most common cause in the torch. Okay, you know the torch. T, toxoplasma. O is others like syphilis, HIV, and hepatitis B. R is rubella. C is CMV, and H is herpes, simply herpes and syphilis and all these group. Okay. So what is important here is that CMV produces very clearly. Oh, I'm so sorry. Just a minute. Okay. CMV produces what is called as cytomegalic inclusion bodies, that you should know. Clinical features, there can be a low IQ because of mental retardation, microcephaly, developmental delays, seizures. Features of chorioretinitis, sensorineural hearing loss is also one of the very common features in cytomegalovirus infection. Very similar to congenital rubella infection, this also causes sensorineural hearing loss, where you have actually this could be the only finding also even in CMV. Hepatosplenomegaly, all this is there. Cardiac side effects are seen in congenital rubella syndrome, not seen. So this is nil cardiac defects almost. The CMV doesn't produce cardiac. It is essentially neuro, eye, all these features, ear, essentially in the brain. Investigation, CMV positivity or IgM CMV antibodies. Imaging shows the classical periventricular calcifications. Okay. Now questions. A 9-month-old baby presents with deafness, cataract, PDA. Clear? I told you cardiac is not CMV. Cardiac is usually, yes, very good, congenital rubella syndrome. Herpes simplex doesn't produce cardiac. Toxoplasma produces liver and brain very significantly. Cataract, hepatosplenomegaly, brain, that is congenital toxoplasmosis. This cardia, no, always look at rubella. Child presents with fever, rash starting from the face, behind the cheeks, buccal mucosa spreading to rest of the body. Very simple clue they gave, Koplik spots. Answer is measles. Very, very, very simple. A 3-month-old infant born to mom with HIV, recurrent diarrhea. What is the next most important step? Now, 3-month-old baby is around that 12 weeks, okay, maybe around 13, 14 weeks. Presents with recurrent diarrhea. So now our doubt is, does this child have HIV? Why the child has recurrent diarrhea? Now there could be, we have seen children who are born to HIV mothers where the diarrhea could be because she chose exclusive formula feeding and was unhygienic. Yes. But what is your appropriate step when you know the mother is HIV positive? You have to ensure that the baby is HIV positive or not, so that your evaluation for diarrhea, okay? So evaluation of diarrhea goes totally different if it is HIV positive neonate and HIV negative neonate. So HIV positive neonate, what are you going to do? You're going to look for opportunistic pathogens, cryptosporidium, giardia, okay, all these. And if it's HIV negative, you're going to look for small infections, poor bottle handling, all these things. So what is the most important step? Is it concerned conduct an aerobic culture? No. Antibody test for HIV can be done only above 18 months, cannot be done in 3 months. Stool for GRD and admit antibodies? No, that is only if your child shows that he is immunosuppressed. So what you're going to do, you're going to do that first. You're going to check for a dried blood spot for HIV DNA PCR. Quick look at common bacterial infections. Diphtheria, you all know Corynebacterium diphtheriae, incubation period 2 to 4 days. Mode of spread, respiratory droplets or aerosols. Clinical manifestations, typical diphtheritic bull neck appearance. Bull neck is the lymphadenopathy bull neck appearance with a white patch on throat. White patch on throat, typical Corynebacterium diphtheriae. We are also seeing it with diphtheroids. So fever, severe sore throat, white patch on tonsil with bull neck appearance. This the membrane may spread downwards because it's a very significant diphtheritic toxin, very bad toxin. So because of the toxin effect, you can have laryngeal bronchial spread, and you may have the membrane there also, which can result in stridor, hoarseness, cough, etc. How do you diagnose it? You're going to do a swab test, doing what is called an Albert's stain. Now this was asked in the pediatric section, strangely. This Albert stain is where you have these metachromatic granules which are seen on the diphtheria, because this is the club-like appearance. That is because the metachromatic granules. Okay. Treatment is very important. Antitoxin, diphtheritic antitoxin. Diphtheria toxin affects the kidney, affects the heart, affects local. It's a local toxin, it's a neurotoxin, it's a cardiotoxin. So, and it can also affect the kidney. Cardiotoxic effects are very significant. Neurotoxic effects very severe, can cause local palsies, as well as it can cause local tissue edema and issues. So antitoxin, diphtheritic antitoxin is very important, should be given. Antibiotics, because the bacterial infections, most common antibiotic use are penicillins and macrolides. Pertussis, Bordetella pertussis, mode of spread, same pathogenesis. Again, this important thing is it also produces a lot of viremia and local tissue. It causes something called histamine sensitivity, insulin secretion, and leukocyte dysfunction. These are the important things which the pertussis toxin causes. Please remember this, okay? Clinical manifestations, 3 phase. You have the catarrhal phase, this you all know. The paroxysmal phase, and you have the convalescent phase. Pertussis is called the 100-day cough, where there's a cough, cold, then an inspiratory whoop, and then there's a persistent cough. The whooping can be, the cough can be so bad that there can be conjunctival bleeding, subconjunctival hemorrhage, facial petechiae, etc. Diagnosis primarily clinical, and IgM for this and swabs are not commonly done. Treatment is with antibiotics. The typical antibiotic used are macrolides. Congenital syphilis, you all know this, Treponema pallidum. Treponema pallidum. Mode of spread is usually vertical transmission in neonates. Clinical manifestations can cause intrauterine death also, and can also present with systemic features like hepatosplenomegaly, bleeding complications, neurological features, this facial features like the Olympian brow, the Hutchison's teeth, Olympian brow, Hutchison's teeth, mushroom mulberry molars, all these are common features, okay? With global developmental delay, depressed saddle, the nose is totally depressed, a saddle nose, all these are features. Persistent rhinitis called sniffles, all these are features of congenital syphilis. Diagnosis is, we do the VDRL, RPR test initially. After that, the Treponema pallidum Hemagglutination test is diagnostic. Treatment is antibiotics, yes, here also. And we have to make sure that the earlier the diagnosis, the better the neurological outcome. That is why antenatal diagnosis and management with penicillins for a newborn who's born to VDRL positive mother, if the baby is positive, should be done. Penicillins are the drug of choice. Immunology and allergy. Okay. Now here, I thought I'll just reverse the thing. You might be kind of getting a little bit exhausted. So now we'll do the questions and then the topic, okay? Child presents with failure to thrive and recurrent infections. Absent tonsils, okay? Very, very important. Investigations. Oh, okay. I'm sorry, just a minute. This seems to be jumping. Okay. Child has absent tonsils. Further investigations reveal a deficiency in ADA. That even without that, you people should be able to get the answer. Deficiency in ADA, what's the most likely diagnosis? ADA deficiency, absent tonsils, recurrent infections. This is a primary immunodeficiency. ADA deficiency is typically SCID, severe combined immunodeficiency. Ataxia telangiectasia, Leishman syndrome, Friedreich's ataxia should have neurological features. This is neurologically normal child. Okay. So SCID is the absence of all adaptive immune functions, and here this is a defect in the common gamma chain. The infections are recurrent, child is unable to overcome these infections. Every infection becomes a very severe infections. There is something called the Jeffrey model criteria. You all should know this for immunodeficiency, for red flags for immunodeficiency. When should you evaluate a child? Okay. The important thing with SCID is that the infant lacks ability to reject a foreign graft. Treatment is usually these children do not survive long. So early diagnosis is stem cell therapy or gene therapy, and usually the diagnosis should be made in the first 1 to 2 months of age, earliest by less than 3.5 months. Only then you can treat them successfully. A mother brings a 2-year-old child to the outpatient department with poor weight gain, abdominal pain, and poor eating. Okay. Child was advised a gluten-free diet, after which the child has a much better improvement. So what is the most likely diagnosis? NEET 24. So very clearly, where do you avoid gluten? You avoid gluten where the gluten is not digested appropriately, or there are antibodies to gluten, and that is seen in a condition called celiac disease. Okay. So intestinal malabsorption will not improve with gluten-free diet. Whipple's disease will not improve with gluten-free diet, and Whipple's disease does not have childhood presentation at 2 years. Very, very rare. Tropical sprue is an acquired condition altogether. It does not have anything to do with our gluten diet initially. It's an acquired condition, older children. Okay. So the correct answer is celiac disease. 11-year-old child, diarrhea, weight loss. On examination, both are less. So there is chronic malnutrition. Okay. Lab investigations they have done, they found HLA-DQ2 positive, which is very significant. What is the most appropriate dietary recommendation? Now let's see. Now you had diarrhea, weight loss. Okay. Now in gastroenterology, the 11-year-old child with diarrhea, weight loss, why will they do HLA-DQ? They will do HLA analysis only if you're considering celiac sprue. And HLA-DQ2 is positive in celiac sprue. So this child's diagnosis is celiac sprue or celiac disease. What is the recommendation you will do? You will do a gluten-free diet. Low carbohydrate will you do in a child who is already having less weight and height? No. Lactose-free diet, it is good in a child with weight loss, lactose-free diet. However, that should be in a child who is proven to have secondary lactose intolerance by the presence of reducing sugars in the stool. Okay. Fat-free diet, no use. He is already malnourished. So what is celiac disease? This seems to be a quite pet, question. I've seen it in many papers. Gluten, it's a protein found in wheat, barley, rye, etc. Here there are antibodies formed to the gluten component, and that results in a gluten sensitive enteropathy, where they have extraintestinal manifestations along with this diarrhea and weight loss. So the genetics, which is, you already know one, HLA DQ2. Another one is DQ8. Both you should know for celiac. Intestinal features, you have vomiting that can result, you can have diarrhea. Constipation is also, now remember, all children don't have both. I have seen children who present with persistent diarrhea. They are the easy to diagnose. We have children who have roamed around with diagnosis of constipation. Pain abdomen is very classical. Iron deficiency anemia, and this is the most common cause of chronic diarrhea in children. Remember, you have chronic diarrhea, persistent diarrhea, acute diarrhea. Remember those in diarrhea. Short stature is there, rickets and osteopenia, all because of malnutrition. Okay. Now, how are we going to, what are the differential diagnosis, sorry, how are we going to diagnose this? You're going to tissue transglutaminase antibodies. TGA, TTG, or the tissue transglutaminase antibodies, upper GI scopy, okay, and you're going to do for deaminated gliadin peptide. Okay, they are the three diagnoses. Management is, you all know, gluten-free diet for life. Okay. Now coming to gastroenterology and endocrinology. Lactose intolerance. Now, lactose intolerance, these all came very similar as DDs. Now, the most common enzyme deficiency we have is the deficiency of enzyme lactase. Now, this lactase, you have primary deficiency and you have secondary deficiency. Primary deficiency is what brings up what is called primary lactose intolerance. Secondary deficiency occurs after a bout of diarrhea, that is secondary lactose intolerance. What are the clinical features? The clinical features are explosive diarrheas, frothy stools, lot of perianal excoriation and redness because of the lactic acid burning the perianal skin. You have bloating, pain abdomen, vomiting, all this. Okay. Management is reduce the lactose in the food. Now, first, how do you diagnose? You can present positive reducing sugars in stool based upon the amount of the sugar. If you have red, yellow, orange, or green, or blue, so positive reducing sugars. Management is reduce the lactose containing foods. Increase complex carbohydrates. Essentially, the child will get better. The zinc supplementation, more than 6 months, 20 milligram per day, less than 6 months, 10 milligram per day, and lactose-free diet. So, what is diarrhea? Now, diarrhea is the passage of loose water stools 3 times within a 24-hour period. Okay. So, acute diarrhea, less than 2 weeks. Persistent diarrhea, up to at least 14 days. Okay. And chronic diarrhea, which persists for more than 2 weeks and goes on for up to nearly 3 months. So, many months also it can go. So, if an acute diarrhea lasts for up till 14 days, it is called persistent diarrhea. If it goes on beyond 14 days for months together, it is chronic diarrhea. Dysentery. Dysentery is presence of blood positive in stool. Okay. Most common cause of diarrhea, you have viral diarrheas. Okay. Viral diarrheas are the most common cause of diarrhea. You also have bacterial viral or rotaviral, Norwalk, calicivirus, all this. Bacterial diarrheas. Bacterial diarrheas are essentially enterotoxigenic E. coli, enterohemorrhagic E. coli, traveler's diarrhea, toddler's diarrhea, all these are the E. coli which are toxigenic. Okay. Then you have salmonella, shigella, klebsiella, all these are the bacterial diarrhea. Fungal diarrheas in immunocompromised, cryptosporidium, giardia, all these are fungal diarrheas. Okay. Clinical features, presence of loose stools, and the loose stools are essentially associated with abdominal pain, vomiting sometimes, dehydration, presence of blood in the stools, and complications like acidosis and death. Okay. Okay. I think this is okay. Now, antimicrobial therapy. Remember, antimicrobial therapy is not given in viral diarrheas. Antimicrobial therapy, you should prove bacterial diarrhea. That is by essentially pus cells in the stool or by the child having blood in the stool or some such clinical features. So, when do you use antimicrobial therapy? We use in severe malnutrition. Okay, severe malnutrition, immunocompromised, HIV child, when there is dysentery. The dysentery essentially is bacterial infection, enterohemorrhagic E. coli, Shigella, Salmonella, things like this. Then you're going to use antimicrobial, antifungal therapy in fungal diarrheas. You will use when there are signs of sepsis or septicemia, meningitis as a complicated diarrhea. Okay, that's when you're going to use antimicrobial therapy. Anti-motility drugs contraindicated in children. Now, ORS is very important. We discussed it last time. Remember, by osmolarity as well as by weight. Both you must know. Sodium chloride 75 millimoles per liter, potassium 20 millimoles per liter, trisodium citrate 10 millimoles per liter, glucose 75 millimoles per liter, in which you're going to look at the chloride giving 65 millimoles per liter, and water, you're going to bring it up to 1 liter, which gives 245 millimoles per liter, which is low osmolar ORS. Okay. By weight, sodium will be 2.6 grams, potassium 1.5, trisodium citrate 2.9, glucose 13.5 to 1 liter. Because the chloride is not measured separately, because it's a part of the sodium and potassium chloride. Okay. A 3-month-old baby presents with jaundice and clay-colored stools. Lab investigation to reveal conjugate hyperbilirubinemia. Liver biopsy shows periductal proliferation. Periductal proliferation with conjugated hyperbilirubinemia. Jaundice, clay-colored stools. What is the answer? It means it is obstructed jaundice. Obstructed jaundice. The answer is biliary atresia. None of the others will have clay-colored stools. So, biliary atresia produces because of bile duct obstruction, liver damage and death. There is jaundice which develops within the first 3 to 4 weeks of age. It's conjugated jaundice, pale or porcelain clay colored stools. The diagnosis is HIDA. Now, HIDA is a screening tool. Okay. Confirmation is liver biopsy. Remember this very well. Confirmation is liver biopsy. Management is Kasai's portoenterostomy. Okay, followed by the corrective surgery like liver transplant later on. Complications, if undone, excuse me, if not done earlier, liver cirrhosis, portal hypertension, ascites, liver failure and death. Now, adrenal disorders. Most important is the congenital adrenal hyperplasia. The inheritance is autosomal recessive. Defect, it's a cortisol deficiency. Okay. Excuse me. It's a cortisol deficiency that increases the secretion of ACTH, and this adrenocortical hyperplasia results with production of intermediate metabolites. So the enzymes which are deficient are 21 hydroxylase, 11 beta, 3 beta and 17 alpha hydroxylase. Most common is the 21 hydroxylase deficiency. Okay. So clinical features, just the important in 21 hydroxylase deficiency, you will have acute sick neonate. Hypotension, shock, hyponatremia, hypokalemia, hyperkalemia, everything will be there. Okay. Along with hypoglycemia. Very sick child. Has to be attended to in the neonatal period. If along with this, child may also show ambiguous genitalia, virilization of female genitalia, and in a boy can evolve, mild varieties can evolve to non-salt losing type can evolve into precocious puberty. In the 11 beta hydroxylase, important is not hypotension, hypertension, okay, because aldosterone is more, it produces increased BP. There, in all, you will have hypoglycemia. Here also, precocious puberty ambiguosity is there. In the 17 alpha hydroxylase, your aldosterone is increased. In 11 beta hydroxylase, aldosterone is reduced. I'm sorry, there's 11 deoxycortisone which is increased. Aldosterone is increased in 17 alpha hydroxylase. Here again, BP is increased. Hypotension, hypertension, all of it will decide which side your diagnosis goes. All will have precocious puberty and virilized genitalia, okay? And all will have hypoglycemia. Diagnosis is with 17-hydroxyprogesterone. Treatment is with glucocorticoid. Glucocorticoid used is hydrocortisone. Dose, I'll write 15 mg per meter square per day in 3 divided doses. Mineralocorticoid is fludrocortisone, usually used in children with salt losing type of disease. Now, a 7-day-old newborn, part of other endocrine questions, TSH of more than 100 millunits per liter. What is the next best investigation to perform? Now, you know that the TSH is high, which means there is some bit of thyroid at the gland is having some issue. So, you want to know what is happening to the gland because brain seems to be okay, TSH is high. So, what you will do is the radio tracer iodine uptake with technetium. This is because if there is no thyroid hormone, then you're going to see what is happening. Is there dysharmogenesis? Is there poor iodine transport? What exactly is the problem that you have to see? So, doing a thyroid antibody is not the solution anymore. You're going to do a radio tracer uptake with technetium and see the radionuclide scan. Urine iodine excretion doesn't make any sense. Perchlorate test is not the answer. Okay. A neonate is diagnosed with congenital hypothyroidism through screening with low T3 and T4 levels. No uptake on radioiodine scan. So what does it mean? But your gland is there on ultrasound. Iodine uptake is not there, but gland is there. So what does it mean? What is the transport issue? The transport issue is in defective iodine transport. It's a very straightforward question. In dishormonogenesis, you will have uptake. However, the hormone synthesized will be abnormal. So that is different. Thyroid agenesis, you will not have gland at all in ultrasound. Deficiency of iodine, you will have a totally different cretinous presentation, not in neonate. Okay. So it is defective iodine transport. So congenital hypothyroidism, very simple. Most common cause is thyroid dysgenesis. Dishormonogenesis, defect in thyroid hormone transport and all are much less common. Thyrotropin receptor blocking antibodies is when the mother is on such medication or she is having some antibody disease, Graves, etc. in the mother. This is primary gland induced. The secondary or hypopituitary type of hypothyroidism is where you have TSH, TRH deficiency or receptor issues where you have TRH unresponsiveness. Cretinous features are the most important. You know Cocker, Debris, Semi-Lange syndrome. I told you this is one of the rare causes of disproportionate short stature. Otherwise, hypothyroidism is proportionate short stature. Thyroid profile. You have low T3, T4 with raised TSH, ectopic thyroid, look for the radionuclide gland. If there's no uptake, do a gland scan and see whether it's agenesis or it is iodine transport issues or if there's increased uptake. Okay. ECG to look for this low voltage complexes and elevated serum cholesterol will be seen in cretin children. Now coming to neurology, identify the condition seen. Very clear. Now they have pointed it out also. I mean, I hope they've actually pointed out in your screen. This was the image which we got. So here, now this is the posterior fossa defect. There's a defect in the posterior fossa. And what do you see? You see near the base of the cerebellum, there is increased dimension and there is a malformation. So corpus callosum, this is corpus callosum. Okay. Corpus callosum is up here. So it is not corpus callosum. Corpus callosum is seen nicely here. Okay. Vein of Gallen malformation is up here. So it is not vein of Gallen. Dandy-Walker malformation should be in the posterior fossa here, but it should see it as a large cyst. This is a malformation at the base of the cerebellum. So this base of cerebellum you see what you call the Chiari type 1 malformation. So the correct answer is D. Now, other ped neuro hydrocephalus. Hydrocephalus is increased production of CSF, either because of the increased production or decreased absorption. So it's obstructive or communicating. Increased productions are usually communicating. The decreased, the obstructive ones are the ones which have the, which is where there's obstructive defect like aqueductal stenosis, etc. Okay. So congenital hydrocephalus, you have aqueductal stenosis, Dandy-Walker malformation, vein of Galen, Arnold-Chiari, rarely torch infections. Acquired, if you have any growth of any tumors in that area, could be a choroid plexus papilloma, cyst, arachnoid cyst. If you have post-meningitic sequelae where you have that deposits blocking at the foramen which are much below, tubercular deposits typically, intracranial hemorrhage where the clot and the fibrin get deposited at the base and thus block the CSF drainage, traumatic brain injury. Diagnosis, as long as the anterior fontanelle is open, it is a neurosonogram. Above that, it is only MRI. Once AF is closed, it's only MRI. What do these children present with? Essentially sunsetting, increased head circumference, a crackpot skull kind of noise. You can shine a torch and you can see the distended CSF in the brain. Sutures are open, features of raised ICT are there, sunsetting sign is there. All these are features. Treatment is obstructive hydrocephalus, you have to open the obstruction, put a VP shunt. Communicating hydrocephalus, put a VP shunt, and if it is because of a choroid plexus issue, you can give acetazolamide. Okay. Posterior fossa malformations, primarily 3, Chiari 1, Chiari 2, and Dandy-Walker. This, I told you, no, the cerebellum issues are essentially Chiari type 1. Okay. Arnold-Chiari type 2 will have, along with cerebellum, a meningomyelocele. That's what you should know. Type 2 has meningomyelocele, usually right up here or sometimes down. And Chiari type 1 has cerebellum tonsils get displaced below. Okay. Dandy-Walker is a huge cyst. It will be like a small empty dark area at the base of the brain where you're expecting the nice configuration of cerebellum. Okay. So that is Dandy-Walker malformation. Okay. So let's come to pediatric seizures. A 7-year-old child presents in the emergency department with fever and convulsions. What will you do? Most important, immediate intervention. So what is your immediate plan? Your immediate plan is to stop the seizures. Okay. So when you have stopped the seizures, what you're going to do? You're going to do short-acting benzodiazepines. Short-acting benzodiazepines are the best option. That is essentially midazolam. However, that is not there in the option, means you look for other benzodiazepines in the option, which could be lorazepam or diazepam. Okay. So first control the seizures, then search for etiology, because it should not evolve into status epilepticus, which will have poor prognosis if the brain remains hypoxic during the seizure phase. That is why your correct answer is diazepam. Valproate, ethosuximide, fosphenytoin, all may be treatment of this child's underlying epilepsy if it is there. But immediate intervention is always diazepam. Okay. Then evaluation. A 9-month-old child again brought with jerky movements. Upon examination, neuroregression is seen. Okay. The EEG shows hips arrhythmia. This is a big clue. Where do you see hips arrhythmia? You see hips arrhythmia in infantile spasms. Earlier used to be called, okay, what is the treatment of choice? Adrenocorticotropic hormone. Others are not typically drug of choice. Steroids with ACTH all are for infantile spasms. Now coming to a very commonly asked question set, it is from febrile seizures. Febrile seizures are seizures occurring in children who are developmentally normal. I have written in caps also. That's how important it is. Developmentally normal child having seizures when the fever is above 100.4, age typically 6 months to 6 years or 6 months to 60 months, either way you remember it. No other cause is found, occurs on the first day of fever, within the first 24 hours of fever, only one episode lasting less than 15 minutes. This is febrile seizure. Anything else is atypical febrile seizure. Okay. Now, This is the most common cause of seizure below 5 years of age. Now you have simple febrile seizures, complicated febrile seizures. Whatever I told you will come under simple febrile seizures. Whatever outside of simple febrile will come as complex febrile seizures. That the diagnosis is clinical. Okay, there is no diagnosis, management, no diagnostic test which is needed. Diagnose the fever, diagnose the febrile seizures, clinical. Management is antipyretic. Remember, this is the management. Okay, prophylaxis is there with clobazam, which is given in anxious parents, otherwise no. Okay, clobazam prophylaxis. Okay, otherwise nothing. This whole thing, lumbar puncture, neuroimaging, done when in doubt. When in doubt whether the seizure is typical, atypical, only then do you do any test for febrile seizures. Otherwise, it's clinical diagnosis. Antipyretics, rescue medication, prophylaxis is clobazam. Okay. Now, epilepsy, it is the ILAE definition, which is the International League Against Epilepsy. Remember this, ILAE definition. This had come out in 2017 with updates after that. 2 unprovoked seizures lasting 24 hours apart is diagnosis of epilepsy or seizure disorder. Or there is a diagnosis of an epilepsy syndrome which is made with EEG findings also. Okay. Same ILAE has said that when you have recurrent seizure lasting for more than 5 minutes, then it is status epilepticus. Okay. Or no recovery of consciousness between 2 episodes of seizures, then it is status epilepticus. Continuous convulsions for more than 5 minutes or no regain of consciousness between 2 episodes of seizures, then it is status epilepticus. Okay. The ILAE classification divided that generalized, partial, all that they removed. They made focal and generalized. And this they decided as focal aware or focal impaired awareness. Focal aware means the child is simple partial seizures, where the child is aware, only one hand is moving, able to reproduce the seizure to the doctor. And they can be like behavioral onset, autonomic features, tingling, numbness, all of it can come under simple seizures, which a child is completely aware. There is no generalized features. Okay. Impaired awareness is where the child cannot remember the seizure and the child loses consciousness. Okay. Generalized seizures is where the seizures don't start in one part, the seizures start all over the body at once. That is what differentiates generalized and focal. Types are motor, tonic, clonic, absence, atonic, myoclonic, spasms, all are generalized seizures. Okay. Unidentified and seizure syndromes are always there. West syndrome is also called infantile spasms. That's what I discussed there, where you have developmental delay, hips arrhythmia with infantile spasms, usually diagnosed less than 1 year of age. You can have flexor spasms called jackknife spasms. You can also have extensor spasms. Child completely arches back like that. And the sudden spasms keep happening and there's developmental delay. Now here you may not find anything much in the MRI, but EEG will show the typical high voltage chaotic background activity with multifocal spike wave discharges. Please remember this. Okay. ACTH is the therapy, otherwise steroids. Vigabatrin is an important alternative therapy. When you have tubercular sclerosis associated infantile spasms, the drug of choice is vigabatrin. Status epilepticus, I taught you the definition. Acute, ABC always. Then benzodiazepine, okay. If uncontrolled with benzodiazepine, proceed. IV phenytoin, fosphenytoin, from fosphenytoin to valproate, valproate. Now from valproate, we are deciding whether to go for here, whether there is levetiracetam. All these are levetiracetam or fosphenytoin. So if you start with levetiracetam, then go to fosphenytoin, start with fosphenytoin, go to levetiracetam. From levetiracetam, you can directly go to sodium valproate like that. And from there, we are going to phenobarbital and then midazolam induced infusions. Okay. The more you go further, the poorer are the outcomes. A child who underwent successful VP shunting for hydrocephalus has fever, Nuchal rigidity and irritability 4 months post-op. You suspect the child has meningitis. What should you do? Now, why does this child have meningitis? Because you said fever, nuchal rigidity, irritability. Okay. Now, for the meningitis, what is the option that we can do? Now, this is a child who has a VP shunt. So, we are suspecting where the foreign body in the brain is, that is where the infection is. So, what you'll do first is you're going to first do a shunt analysis with cultures from shunt. Now, after that, you will manage the child's antibiotics, say blood culture, etc. So, let's see which option fits. A. Perform blood culture and correct CSF sample via lumbar puncture. Purposeless. You are suspecting a shunt infection. So, no point. B. Collect CSF sample from shunt. Absolutely. Shunt patency using nuclear imaging. No, we know the patent shunt is patent. Child does not have sudden increasing head circumference. Child is having meningitis. Monitor the child. No, never. Correct answer B. Take culture from the shunt. Pyogenic meningitis, you all know this. It can start with any focus. Focus can be in upper respiratory tract, can be in ear, can be in throat, can be in lung, anywhere the source can be. Okay. The etiology I discussed in the neonatal group, where E. coli, GBS, all this become in small babies, in older babies, Streptococcus pneumoniae, Haemophilus influenzae, and Neisseria in older children. Okay. You have meningitis, a headache, vomiting, photophobia, phonophobia, dull, sick child who will also have on examination can have seizures, altered sensorium, nuchal rigidity, positive Kernig and Brudzinski signs, neck sign, hip sign, all possible. Waterhouse-Friderichsen syndrome is what you see with severe meningococcal toxic shock, where meningococcus affects the adrenal, causing hemorrhage in the adrenal. Okay. Empirical therapy, you will start with third generation cephalosporin, which is typically ceftriaxone at a higher dose of 100 mg per kg per day. Once you have done the CSF and diagnosed, then you can go for specific therapy. 11-year-old boy presents with seizures. There's history of febrile illness with rash at 1 year of age, which is resolving on its own. Which investigations would be useful in diagnosing his current condition. Now, a 11-year-old boy, to see how further it goes, why should 11-year-old boy have seizures? One, he could have developed some acute cause. So, by understanding of these options, there is no acute cause. They have given you a history that there was a febrile illness with rash. Remember, in all this NEET and all, no, most febrile illnesses with rash are essentially measles, unless otherwise proved, essentially measles. So, this child seems to have had measles, and post measles at 11 years, he has seizure. So, what are you thinking this is? This is a chronic slow complication of measles, which is a subacute sclerosing panencephalitis. How would you diagnose that? Subacute sclerosing panencephalitis is diagnosed by, after 10 years, which antibody will be available? It is not the IgM. It is the IgG, measles in the CSF is the diagnosis. C1q4 antibodies are not for measles at all. IgA, you cannot diagnose IgA in measles. And MRI showing mesial temporal lobe sclerosis does not represent the measles. So, none of these are the right answer. So, SSP, persistent, very low, mild, latent or indolent measles virus infection in the CNS can last up to 5 to 10 years. Here, slowly this neuroregression, jerks, behavioral abnormalities and cognitive decline. No cure, treatment is with control of seizures, supportive care, etc. Remember, the CSF measles IgG is diagnostic. EEG may show something, MRI will show deaf brain atrophy. Okay, there is no role for any other therapy. It's very chronic, like this prion disease. It's like that. Coming to nephrology. A child presents with edema, hypercholesterolemia, 3+ protein and fat bodies in the urine. Open book. What's the diagnosis? Nephrotic syndrome. IgA nephropathy, good picture, so all should have hematuria. Okay. A 3-year-old child presents with edema, anasarca. Diagnosis of minimal change. So, chalo, we have comfort to diagnosis of minimal change nephrotic syndrome. Which is true? Will you have non-selective proteinuria in minimal change? Does it have a good common incidence in adults? Is there a good response to steroid in this child? Light microscopy shows effacement of basement membrane. So, It's not a non-selective proteinuria. The high proteins don't go. It's a selective proteinuria. It is most common in adults. No. Light microscope shows podocyte basement membrane effacement. Okay, so this is also wrong. But minimal change has got a fantastic response to steroids. That is the drug of choice. So massive proteinuria, more than 1 gram per meter square per day. Hypoalbuminemia, less than 3 gram per deciliter. Edema or anasarca, hyperlipidemia, typically cholesterol. Food process effacement results in proteinuria, and in a normal light microscopy you will find normal. The other types of nephrotic syndrome are focal segmental, membranous, mesangial-proliferative and membranoproliferative. All these are very complicated in treatment, will not respond to steroid, will need biopsy and will need for other cyclophosphamide and other kind of drugs. So urine dipstick showing 3+ to 4+ proteinuria. The pediatric criteria is more than 40 milligram per meter square per hour is the proteinuria which you should measure in the 24-hour. Serum albumin is very important. Serum cholesterol very important. Urine spot protein creat ratio more than 2 is spot diagnosis of nephrotic syndrome. Management, steroids 60 milligram per meter square per day. Remember that equals to 2 milligram per kg per day. Okay, you will give this for 6 weeks. After 6 weeks, to 3-day consecutive urine negativity to document remission. Shift to alternate day dosing is 40 milligram per meter square per day, and urine albumin again, and then taper and stop. Important along with this is BP monitoring, dietary management with reduced salt and fats. Both should be reduced. Water intake is restricted only in 3 situations where you have genital edema and you have respiratory distress. When you have cardiac failure because of severe pericardial effusion, when you have vulval, scrotal, genital edema, and so you can have infections. And when you have severe respiratory distress, that's when you're controlling water in nephrotic syndrome. Okay. PSGN is nephritic syndrome. Etiology is group A beta hemolytic streptococci, affects age group 3 to 12 years. Most commonly it's called the school age group because it comes from child to child. Hematuria, mild proteinuria, hypertension. Most important triangle. Okay. Sudden onset of hematuria, to oliguria, hypertension, headache, mild elevation in blood urea will be there. Prodromal features may be there. There will be a past less than 4 weeks history of a sore throat needing antibiotics. That will be a history which you will get. Treatment is treat the hypertension with antihypertensives carefully. If the child is in AKI, manage the acute renal insufficiency. Antibiotic is given for 10 days to eradicate any infections which may be there. Now remember, there are 2 things, either sore throat or you have nephrogenic strains in the skin. So to clear the impetigo in the skin, both of which you have nephrogenic skin strains. The sore throat strains are more common for rheumatic cardiac disease, but we do have sore throat for post-streptococcal glomerulonephritis also. Skin bacteria essentially do not cause cardiac disease. The skin streptococci are essentially nephrogenic if they are there. That is why you are giving penicillin that takes care of this nephrogenic streptococci and does not allow the disease to come back. So other differential diagnosis of hematuria is henoch-Schönlein purpura, on IgA vasculitis, IgA nephropathy, which is Berger's disease. Henoch-Schönlein purpura is essentially a IgA small vessel vasculitis where there is palpable purpura in the lower limbs along with abdominal pain, and you can have complications also where you have vasculitis in the brain, etc., and other renal involvements. Okay, corticosteroids is the treatment of choice. In IgA nephropathy or Berger's disease, this is essentially a genetic condition where every time it is synpharyngitic. Every time there is a sore throat, they will have hematuria. Okay, renal biopsy will be there. Treatment is, if there is hypertension, monitor for hypertension and manage it. Next question. Child with abdominal pain and arthralgia on physical examination, palpable purpura is noted on the lower limbs. We discussed palpable purpura, upper respiratory infection is there. So when you have palpable purpura, what is your diagnosis? Henoch-Schönlein purpura. Palpable purpura, lower limbs. What is the treatment? Glucocorticoids. These all not used for Henoch-Schönlein purpura. Okay. So touch on acute kidney injury. Pre-renal kidney injury is where the blood supply to the kidney has had issues, like in dehydration. Okay, dehydration, sepsis, shock. Intrinsic renal kidney is when there is damage to the kidney per se. So there you will have post-streptococcal, SLE, HIV. Other causes are like HUS, snake bite, which causes interstitial nephritis, tumor lysis syndrome, drugs, toxins. All these are intrinsic kidney issues. They all will be with the basal membrane, interstitium of the kidney, all these things, pyelonephritis, all this. Post-renal kidney injuries where there's obstructive, typically obstruction. Obstruction you will see in posterior urethral valve, PUJ, bilateral PUJ obstruction, very rare, but yes. Urolithiasis, neurogenic bladder, which can occur with spinal injury, spinal dystrophism, and spinal tumors. What do? Pre-renal, dehydration was the cause, sepsis was the cause, shock was the cause. So treat the dehydration, give the fluids, give the antibiotics, give fluid replacement, watch for the BP and urine output. Intrinsic renal kidney, watch carefully what is the cause. If the cause is a drug, cause is a poison, make sure you get rid of that poison and the drug as fast as possible, and monitor electrolytes. See if it is oliguric type of AKI, will need hemodialysis. If it is non-uric oliguric type, supportive therapy helps a lot. And if it is obstructive type, of course, you have to do for remove the obstruction either by catheterizing or by removing the PUJ obstruction or treating the posterior urethral valve. So monitor all these things and manage carefully. Fluid, acidosis, electrolyte disturbances, all of it to be managed. Now we have something called the Kidney Diseases Foundation staging criteria. Here you have stage 1, where if the creat is rising by more than 0.3 milligram per deciliter within 48 hours or more than 1.5 to 2 times the baseline within 7 days with a urine output less than 0.5 ml per kg per hour for more than 6 hours, it is stage 1. Stage 2 is a very fast rising serum creat and the urine output remains less for longer. Stage 3 is where it's jumping to 3 times or serum creat is more than 4 or there's an acute increase of more than 0.5 milligram per deciliter, or you need to initiate renal replacement therapy where oliguria is more than for 24 hours and anuria for 12 hours. Okay. A 12-year-old child with CKD presents with bowing of legs, minimal sun exposure, lab findings show low serum calcium, more phosphate and increased alkaline phosphatase with decreased vitamin hydroxy, 25-hydroxy vitamin D levels. Typical, what is this? This is chronic kidney disease resulting in what is called renal rickets. What do you do for renal rickets? You have to treat it. So treat it is with vitamin D along with calcium supplements. Now remember, phosphate binders are not going to treat this child's rickets. Phosphate binders may take care of the phosphate but will not correct the bowing of the legs and treat the rickets. That is why these phosphate binders answers were long. Hemodialysis will only take out more vitamin D until you supplement. Okay. So chronic kidney disease is a GFR based. Here GFR is normal, should be more than 90. If it is between 60 to 89, it is mildly decreased, 45 to 59 moderately decreased, 30 to 45 severely decreased, and if it is below 30, then it becomes very severe decrease. Below 15, it goes into kidney failure. So what are the features of CKD? The features of CKD are anemia, metabolic acidosis, you know all this, hypocalcemia, hyperkalemia and all. How do you treat anemia? You have to give erythropoietin. Iron will not help. Iron is only supplemental over the erythropoietin. Acidosis, you may need oral soda bicarb. Hypocalcemia with vitamin D or that 1,2,5-dihydroxy cholecalciferol, which is calcitriol. Hyperkalemia, try and make sure that you avoid potassium containing foods and drive the potassium intracellularly using potassium binding resins and insulin plus dextrose group if it is acute. Severe hyperkalemia is managed with calcium for cardiac stabilization as well as insulin dextrose group infusion like any other hyperkalemia. Now, a newborn presents with difficulty in breathing. Auscultation reveals gurgling sounds in the chest and the heart is shifted to the right. So, an X-ray shows congenital diaphragmatic hernia. What is the most common location for this condition? Now, diaphragm, this is a shift away from your nephro. So, what is the most common hernia which is responsible? The hernia is called a Bokdalek hernia. Bokdalek hernia is where it's the posterior and lateral. This is the most common. Morgagni's is not common. Hiatus hernia not common in newborns. So the left posterior lateral. Now this sternum and costal cartilage and all are wrong answers. Central tendon, esophageal opening. That's the hiatus and the Morgagni's. Not common. Commonest is Bokdalek hernia, which is the left posterior lateral. So this is the only contraindication for bag and mask. Okay. So here you will find this bubble-like gas shadows in the chest, heart shifted to the right side, and here you can have things like pulmonary hypoplasia. The lung is so smashed that you have pulmonary hypoplasia on this side, but the lung is totally smashed. You see, this child has only this much functioning lung. Here, immediate endotracheal intubation, try and inflate whatever lung there is, stabilize the blood gases and shift for surgery. Now coming to pulmonology, a previous healthy child presents with acute dyspnea. Chest X-ray reveals unilateral hyperinflation of lung. Unilateral hyperinflation. They didn't say unilateral collapse and compensatory hyperinflation. Unilateral hyperinflation. So what statement is true? True is, does he have laryngotracheobronchitis? No. Does the child, in case of obstruction and ball valve mechanism, cause hyperinflation? We'll come to that. A flexible bronchoscopy is used to remove the obstruction. Now remember, flexible bronchoscopy is only for bronchoalveolar lavage. We do not use flexible bronchoscopy to remove the foreign body, because foreign body will, your forceps will not go through it. So flexible bronchoscopy is wrong. A focal area with reduced entry suggests presence of foreign body. Now, when there is unilateral, let's see, this is how this child's X-ray must be looking. Now you have, suppose you have compensatory hyperinflation of this lung. This lung is normal. So this lung is hyperinflated. Why should one lung be hyperinflated? This is because of essential air trapping. When you have air trapping, what happens? Why do you have air trapping? You have the bronchus. Okay. Now this is the right side, which is more vertical, left side which is more. So if you have a foreign body here, during every inspiration, this will slightly open up. The foreign body will not be tightly wedged. So that time air goes in. But during expiration, the airways tend to collapse a bit. That time the air gets trapped. That is why there's unilateral hyperinflation. And this is called the ball valve mechanism. Okay. So this ball valve mechanism causing hyperinflation is a very, very important aspect. Okay. Okay. So quick fix on foreign body aspiration. It's complete obstruction of airways by foreign body with sudden respiratory distress, inability to cough and speak. Most common is the right bronchus, though I showed you left bronchus, but right bronchus, because it's more vertical, is most common. The lower airway foreign body occurs in the bronchus. The management is with rigid bronchoscopy. Upper airway, which occurs in the upper, this one, we can remove it sometimes with laryngoscopy or with flexible bronchoscopy. But lower airway, we need only rigid bronchoscopy. Now, what have they shown here is called the Hemlich's maneuver. Okay, the Hemlich's maneuver is where you keep the child, the mouth opening the lower jaw of the child, keep the child in reclining position where the head is below the leg and tap the back so that the foreign body comes out. Okay. What are the manifestations? There's choking, gagging, foreign body is at the time when the foreign body goes inside. Sometimes the foreign body goes deep inside and the child becomes better. The children who have choking, gagging, and the child becomes better doesn't mean that the foreign body has come out. If these children develop cough, it needs evaluation. Complications, obstruction, erosion, infections because secretions get blocked, fever, cough, hemoptysis, pneumonia, atelectasis, etc. Now, a child presents with respiratory distress and biphasic stridor. 1 minute. Okay. Biphasic stridor. Based on the radiograph provided, what is the most likely diagnosis? See, your radiograph is showing an arrow. What is it showing here? It is showing this narrowing. This is the trachea and the air is totally narrowed. The air space is narrowed. This is called steeple sign. Where you see steeple sign? Steeple sign is seen when there is edema there, and that edema is seen in typically laryngotracheobronchitis. Now the normal airway goes like this. There may be a slight narrowing, and this is called shouldering. There may be a slight shoulder, but this kind of church-like steeple is seen only in laryngotracheobronchitis. Okay, let's see the others. In laryngomalacia, do you have steeple? No. Foreign body aspiration, we discussed what you will have. Epiglottitis, you will see a thumb sign. So none of those are correct. Okay, so let's discuss the causes of stridor. Abnormal low-pitched inspiratory sound, you all know this, it is exaggerated during crying and feeding. This occurs because of a narrow upper respiratory tract. Causes, laryngomalacia is the most common cause of stridor and it's the most common congenital laryngeal anomaly. Here the larynx is typically omega shaped. The child has more distress when supine, it reduces when prone, increases when crying. Okay. Diagnosis is flexible laryngoscopy. This is essential to visualize it. Management is conservative as long as there is no failure to thrive. Remember, if your case scenario shows a child with severe laryngomalacia is having failure to thrive, you have to treat. If failure to thrive is there, treatment is surgery with supraglottoplasty. Okay. Other causes of stridor are subglottic stenosis, vocal cord paralysis, laryngocele, web, vocal cord palsy. Yes. Okay. Now coming to respiratory tract infections, common ones you all know, the viruses which are important. The clinical features are essentially rhinorrhea, cough, and sometimes you may have a reactive airway with wheeze. Diagnosis is to when you look at where is the problem. If you have features of common cold, if you have features of sore throat and pharyngitis, if you have the typical croup is inspiratory stridor, barking cough, and the child is having low grade fever, sick looking with that very prominent stridor, that is croup. Whooping cough we discussed. Bronchiolitis is where the child is tachypneic, wet cough, but on auscultation you're not finding that many creps. That is primarily bronchiolitis. Okay. Management, you have to manage supportively. Each case is managed differently. Common cold, you can manage supportively. Pharyngitis, manage supportively. Croup, laryngotracheobronchitis, what are you going to give? You're going to give nebulized racemic epinephrine, humidified air, all this, and 0.6 mg per kg of steroid IM is the treatment for croup. Whooping cough, antibiotics, bronchiolitis, supportive care, and RSV is the most common cause. Okay. Then laryngotracheobronchitis is what I was discussing. This is viral infection of the glottic and subglottic regions. Then you have most common it's the most common respiratory tract infection in childhood. Okay. Clinical features I just discussed. There is inspiratory stridor, cough, which is called typically barking cough or brassy cough, and low grade fever. This worsens over a span of 2 to 3 days. Chest x-ray, you won't see any major, that mild narrowing called steeple sign. Now steeple sign, if it's very severe, child of severe stridor. Okay. Management is supportive, humidified air. Now nebulization with racemic epinephrine This did exist. However, to get racemic epinephrine is a very difficult option. So that is why one dose, oh, so sorry. Okay. One dose of IM steroid is given in children if the titer is very significant. So this is the mild, moderate, severe group, not so important. Yes, you should know. Epiglottitis etiology is H influenza, most important. It may not be the H Haemophilus influenza type B, but yes, H influenza, non-typable strains also are there. They can cause acute epiglottitis. This is a sick, toxic child presenting with acute onset of stridor, tripod position, drooling of saliva, high grade fever, and sick. Not to examine with tongue depressor because the epiglottis is heavy and will result in severe laryngeal outlet obstruction. X-ray shows this. What is this? This is called the thumb sign of epiglottitis. Okay, it's called the thumb sign. Laryngoscopy done only in either an ICU or an OT circumstances. The management, IV fluid, IV antibiotics, and very careful monitoring. If required, then respiratory support may need to be given till the antibiotics work. Okay. The chloride level in sweat is used for diagnosis of which disease? All of you know. Answer is cystic fibrosis. It is not osteogenesis imperfecta. It is not an neurometabolic disease. It is not an IEM like phenylketonuria. Cystic fibrosis is important. It is autosomal recessive. Remember, the mutation is in long arm of chromosome 7. F508 mutation is the commonest mutation. That is very, very important. Now, the respiratory symptoms with cough, dyspnea, failure to thrive, increased respiratory tract infections are the most common respiratory symptom. Now, the problem is the defective chloride transport. Okay, you can look here, the whole problem, the CFTR protein is responsible for chloride transport. So defective chloride transport is what makes the secretions thick and gluey, can affect the respiratory system and the gastrointestinal system and the pancreas and the intestinal secretions. Okay, so that is why you have genitourinary and gastrointestinal symptoms. Okay, all of this will have risk of UTI, risk of infections, GIT malabsorption features, diarrhea, failure to thrive, nutritional, yes, failure to thrive, lack of especially fat soluble vitamins, features of malnutrition like marasmus with pot belly appearance because vitamin D deficiency causes that visceroptosis. There's acute salt depletion, metabolic alkalosis in the investigations. What you see, you can find these features. Diagnosis is sweat chloride test, then genetic analysis. Management, respiratory management is chest physiotherapy and toileting to remove secretions. We have given nebulized tobramycin to prevent infections. The infections most common which you should know is Pseudomonas. Very, very important. Pseudomonas infection in cystic fibrosis can become life-threatening. Tobramycin nebulizations we have given. There are chest physiotherapy to cause good chest toileting. Nutritional support is very important. And of course, try and make sure that if the child can go into some kind of nutritional recovery programs where the child can be supplemented with nutrition, and gene therapy only, finally, long-term therapy. Okay. Then this is bronchiolitis. Bronchiolitis is the most common respiratory tract infection in children younger than 2 years. Most common is RSV. We have others. We see rhinovirus, we see paramyxoviruses, we see human metapneumovirus, all are there. Respiratory symptoms, 1 minute. Respiratory symptoms, cough, respiratory distress, out of proportion to the chest findings and X-ray. This is what you see. That is, symptoms are more than signs. That is bronchiolitis. Okay. Management is supportive. Now, latest for preterms, because the most common cause is RSV, nirsevimab is the preventive therapy in preterms against RSV infection, which can be life-threatening in preterms. Okay. Now, bronchiectasis. Bronchiectasis is usually primary bronchiectasis is a congenital condition where there's a defect in the cartilaginous tissue in the wall of the bronchus. What we commonly see is primarily secondary bronchiectasis, which is occurring because of persistent chronic infection, inflammatory cycles. This infection, inflammation will cause destruction of the bronchial smooth muscles and elastic tissue, making the bronchus dilated and loose. So you have saccular variety, you have the tubular variety based upon how the bronchiectasis is seen. Okay. Now, bronchiectasis is a common complication which can be seen in asthma, cystic fibrosis, aspergillosis in the lung. All of them can cause bronchiectasis. Okay. Now, cystic fibrosis, the clinical features. What do you see? You're going to see wet cough. Wet cough, large sputum production, large volume. I'm talking about children finding it difficult to sit in the classroom until they go and expectorate the sputum, associated failure to thrive, recurring admissions. And if this is a bronchiectasis with other features like of cystic fibrosis, of cartilaginous or other symptoms, then other syndromic features will be seen. Gold standard investigation is what is seen here. It is the lung where you can see that dilated, typical. You see the glove and sock appearance, you see the inverted glove appearance, you have honeycombing. All of these are seen with the dilated features of the CT scan and the X-ray features of bronchiectasis. Management of bronchiectasis is very similar to management of cystic fibrosis, where chest toileting, making sure there's good postural drainage is very important. Okay. Where the chest is cleared and nebulized mucolytics so that the mucus doesn't accumulate. All these are primarily, and if there's any way like we treat asthma and like we treat cystic fibrosis, if we can prevent, then that's the best thing to do. Okay. Pneumonia, very simple. You all know all this, typical and atypical pneumonias. Typical is high-grade fever, chills, rigors, a typical lobar pneumonia or bronchopneumonia where both lungs will show infiltrates. Common is Streptococcus pneumoniae, Klebsiella, Staphylococcus, all this for lobar and bronchopneumonia. Management, ceftriaxone or amoxicillin clavulanic acid, intravenous, all this for typical pneumonia. Atypical pneumonia are with bacteria like Mycoplasma, Chlamydia. Here the antibiotics are doxycycline and macrolides. Here you have atypical interstitial appearance where you don't have classical features, perihilar opicities, all that you will see in atypical pneumonias. Chest X-ray, that's what I said. Typical, you will find lobar or bilateral equal infiltrates. Here you have perihilar flare, interstitial infiltrates. Okay. Now, IMNCI protocol, you know all this, you know no pneumonia, pneumonia, severe pneumonia, no pneumonia. This is very important, very commonly asked. No pneumonia is fast breathing or chest indrawing is absent. It is just normal cough, cold. If you have fast breathing and or chest indrawing, it is pneumonia. If you have vomiting, convulsions, not able to feed, lethargy, unconscious, stridor in a calm child, or features of malnutrition, it will come under severe pneumonia. 2-3 times I have seen features where the respiratory rate is given abnormally, more than 60, 2 months to 12 months, more than 50, more than 12 months, more than 40. This is the rate you should know. They have given child is having respiratory rate around 42. However, child is all 42. The child's weight for age is 8 kg for 3 years old. And this is, do you think it's no pneumonia, pneumonia is very severe or severe pneumonia? Remember, when you have malnutrition, it is always severe pneumonia. Okay, we'll just go quickly over skeletal system. A 7-year-old child has difficulty walking, struggles to get up from squatting. Muscle biopsy showed this. Now, this is where you have multiple granulocytes or neutrophilic infiltrate in the muscle with destruction of protein. That's what you're seeing here. Okay, so what is correct? So where do you see this? You will see it in muscular dystrophies. Okay, early treatment has excellent prognosis. Is this a mitochondrial storage disorder? No. Excellent prognosis is very difficult in muscular dystrophies. It is only supportive till you reach gene therapy. Viral prodromes, this genetic condition, there's nothing to do with viral prodrome. Death occurs in the third decade, even in the best possible way. Children don't survive beyond the age of 20 in most cases. Quick over this, DMD is an X-linked recessive disorder, dystrophin gene, chromosome is XP21, protein affected is dystrophin. Gower sign is where the child climbs on his own body, like to get up, he will first hold the floor, floor to shin, shin to thigh, and then get up. That is Gower sign. Pseudo hypertrophy of calf is seen, called the inverted bottle appearance, inverted, or the champagne bottle appearance. Waddling gait, which is called the Trendelenburg gait. CPK is markedly elevated. You can get by doing the genetic analysis and the PCR for dystrophin gene, and muscle biopsy does show everything. Okay. Contractures, cardiomyopathies, malignant hypothermia after anesthesia, all these are complications. Treatment, you can prolong life with glucocorticoids. Take care of. Okay. Now, is it from where? From here only? Okay, I can proceed. No, from here? Okay. So the treatment is no problem. I'm good. No issues. So the treatment is with glucocorticoids, and the glucocorticoids only prolong life. They don't completely remove the disease from occurring. Maybe 5-10 years of better quality of life. Treatment of cardiac decomposition and pulmonary infections is very important. Nutritional management is very important. As long as the child lives, nutrition helps in preventing infections, gives a better quality of life. Physiotherapy, yes. Most common cause of, not cause, I would say the most common mode of death is usually respiratory failure, which is occurring during sleep. Okay. Gower sign is what I said. The child climbs up on his or her bodies. The child uses hands and arms to walk up the thighs and climbs up. This is because the proximal muscle weakness. This is seen not only in Duchenne's. Don't diagnose Duchenne's just because Gower sign is given in the clinical features. In Duchenne, in Becker's, or other myopathies, you do see Duchenne's because it just signifies proximal muscle weakness. Okay. Muscular dystrophies, what is Duchenne's, what is Becker's, what is myotonic muscular dystrophy? The Duchenne's and Becker's are X-linked. Both are dystrophin gene. Complete defect is Duchenne's. A partial defect is Becker's. The over 2 to 5 years, you get the clinical presentation in Duchenne's, whereas Becker's is much later, almost in the third or fourth decade. And they are still better off, the Becker's muscular dystrophy. They're still able to reach a near complete quality of life till 40-50 years of age. Quality of life is good, unlike Duchenne's, where you have calf hypertrophy and this features of cardiac decompensation and respiratory muscle failure, all this occurring very much faster. In myotonic muscular dystrophy, this is a totally different component. Here it's autosomal dominant. There is a phenomenon, what is called phenomenon of anticipation in myotonic muscular dystrophy. Here, myotonia happens. Myotonia means once the muscle goes into a spasm, it cannot relax. There is excessive contractibility, inability to relax. So that is what is the myotonic muscular dystrophy. Mother will say child holds hand, cannot leave hand. Child chews food, cannot open mouth for the next food. Okay. The gene is the DMPK gene, chromosome 90. Very classically asked because it's a CTG repeat expansion. Okay, myotonia is what I described here. You have progressive worsening here also. The children don't usually cross the first decade of life. Cardiac conduction defect, distal weakness, all this exist. A 7-year-old child born to non-consanguineous parents, limb deformity consistent with rickets in 6 months of age. Despite multiple courses of vitamin D, these symptoms are there. Okay, so she has rickets, and even though she's taking vitamin D, it is not responsive. Okay, so the investigations show calcium normal, phosphorus is almost negligible in her blood, so it is very less. Phosphorus around this value, less than 5 is good, but it should be more than 2. Alkaline phosphatase is elevated. Rest all seem to be normal. Okay, parathyroid, electrolytes, creatinine, ABG, all normal. Okay, so here we have normal calcium, hypophosphatemia with elevated alkaline phosphatase. So this is vitamin D resistant rickets. Okay, vitamin D resistant rickets, which is also hypophosphatemic rickets. Okay, it is not chronic renal failure because from 6 months till 7 years you cannot have chronic renal failure which is not diagnosed. Hypoparathyroidism, very clearly parathyroid hormone will be very low. Okay, this is not dependent, because dependent means when she takes this vitamin D she is better and child does not have clinical features. Here the child is progressively having rickets even after vitamin D. So rickets is a disorder of growing bones. There's defective mineralization. It is present in children only before the fusion of epiphyses. After the epiphyses are fused, you cannot have that wrist widening, cupping, flaying, none of these features. Okay. The vitamin D deficiency rickets are which can occur with malnutrition, CRF, and there is a type of vitamin D resistant rickets also. That is hypophosphatemic rickets, X-linked hypophosphatemic rickets. Calcium deficiencies, loss in the kidney, in chronic kidney disease, phosphorus deficiency, all these are other conditions which can present with ricket kind of features. From head to toe, you will have the first feature of rickets is craniotabes. First feature of nutritional rickets, craniotabes. From there you go further. Craniotabes, frontal bossing, large anterior fontanelle. Okay, and this frontal bossing. Go down, delayed dentition. Okay, go down. In the chest, rachitic rosary. Rachitic rosary is dilated and enlarged costochondral junctions. Below that, you have Harrison sulcus. This is the groove at the attachment of the diaphragm. Harrison sulcus. Then go down. You have visceroptosis. This is protuberant pot belly. Go down. You will have genuvarum or genuvalgum, that is knock knees or bow legs. Okay. Along with that, in the upper limbs, you will have widened wrists. These are all the features. Along with this, in severe, you can have tetany, stridors, and seizures. Okay, when your hypocalcemia progresses. Okay. In rickets, you also diagnosis is where you have all the features. You'll have hypocalcemia, hypophosphatemia, raised alkaline phosphatase. Nowadays, we are even able to do vitamin D levels with normal creatinine, etc. Secondary hyperparathyroidism is there. Wrist shows, see the typical. There are only 2 wrist x-rays which will come for you all. One x-rays which shows this cupping, fraying and splaying at the metaphysis because of rickets. Another one where the metaphysis looks totally normal, it looks like this. Okay. And you will find that they'll tell you that the child is 7-year-old and you will find only maybe 2 or 3 carpal bones. So where is the delay? Those are all like in hypothyroidism or the constitutional delay where the bone age is behind the height age and the chronological age. So wrist x-ray means any 2 diagnoses only. One is rickets. One, if they give you age of child and then they show you the carpal bones and this cupping flaying is not seen, that's essentially for delayed bone age diagnosis. Okay. So cupping, fraying, rachitic rosary, reduced density of bones. Another place you get a rosary is called the scorbutic rosary. This is a painful rosary. Rachitic is not painful, scorbutic is painful rosary. Pelican spurs in scurvy. scorbutic rosary in scurvy, okay, pseudo paralysis of parrot seen in scurvy. All these also have similar features with pain in lower limbs and all, but will have totally different clinical features. Pseudo paralysis with pelican spurs on X-ray of tibia, and you have this scorbutic rosary is vitamin C deficiency. Rachitic rosary and all this is rickets. Fanconi syndrome is a condition where there is generalized dysfunction of renal proximal tubule. Rickets also happens. You have proximal renal tubular acidosis because of bicarbonate loss. Failure to thrive will be there because of both features. Okay. Rickets, if you're going to treat, then in for the age-wise criteria, 3 months daily dose. This is, I'm telling you, what I'm treating is not prophylactic. It is therapeutic dose. 2000 international units a day for 90 days up to 6 months of age. In 12 months to 2 years, 3000 to 6000, and above 12 years, it goes up to 6000 units per day. Okay. Maintenance doses 400 to 600 units based upon less than 2 to 12 years or above. Okay. Now, there's something called the STOS protocol. The STOS protocol is where you're using the STOS and the mega doses, 60,000 units of vitamin D given weekly for 3 to 4 weeks, X-ray to show for the calcification, and after that maintenance dosing. Okay, this is the STOS protocol. Just a few miscellaneous questions. An ophthalmologist examines a remarkably tall 14-year-old boy with unusually long arms and legs who complains of reduced vision. Findings show ectopia lentis in both eyes. So what is this? Unusually long arms and legs, very tall child, classical. This is a question from genetics. Diagnosis is Marfan syndrome. What is the gene defective in Marfan's? It is fibrillin. Very simple question. Okay. This is Marfan's fibrillin 1, defective collagen matrix formation. DD is always homocystinuria. So always when you evaluate for both and then come to a diagnosis. Okay. I'll just quickly round up because hematology, I didn't find much questions in NEET. There were few questions on iron deficiency anemia, which I'm sure with your background in medicine, all of you will crack. It's very simple, like in pediatrics. So the similar between medicine and pediatrics. So I didn't focus on iron deficiency anemia a lot, but there was a small touch on beta thalassemia. It is autosomal recessive. Here, there is deficiency of beta globin chain, increased fetal hemoglobin and alpha chains. And because of that, the abnormal RBCs, which are defective in these beta globin chains, are produced excessively from the bone marrow, which is called ineffective erythropoiesis, and destroyed in the liver and spleen. And that destruction presents with hemolysis. So, beta thalassemia is one of the most common cause of hemolytic jaundice in childhood. Okay. So, this absent globin gene is because of the replacement of valine for isoleucine. Okay. And what do you see in this? You see that the transfusion start, the need for transfusion. This is a transfusion dependent hemolytic anemia. Transfusion start after 6 months of age because till 6 months the fetal hemoglobin is there in the blood. Okay. So after that the transfusions will begin. Now should a case be presented to you where transfusions have begun before that, please do not take thalassemia as one of the options. Okay. Not beta thalassemia at least. There could be very other rare. I have seen osteopetrosis. We have seen hereditary spherocytosis. These all can present with the transfusion dependency before 6 months of age, but not beta thalassemia major. Okay. And X-ray, if ever done, we don't do it nowadays. Hemoglobin electrophoresis is the investigation of choice. X-ray shows the widened diploid spaces in the skull, presenting this hair on end appearance, and this diffuse osteopenia. Okay. Classic thalassemia phases primarily because of extramedullary hematopoiesis. This extramedullary hematopoiesis occurs in the flat bones, primarily in the flat bones of the face. Why? Because they were the areas where hematopoiesis was occurring in the fetus and in the infant. Okay. So, beta thalassemia major, hemoglobin A will be 90 to 95, HbA2 will be only 3.5, HbF only 1 to 5%. Sorry, minor. In beta thalassemia major, you have a huge amount of hemoglobin F, whereas hemoglobin A will be very much lesser because that's the cells which are dying. And beta 1 and beta plus and beta 0, these are two types of beta thalassemia major based upon heterozygous, homozygous presentation like that. Both equally are transfusion dependent hemolytic anemia. Investigations, essentially diagnostic is hemoglobin electrophoresis. This is the diagnostic investigations. What else you can do? You will find reticulocyte count is more. You will have high Mentzer index. You will find broken created cells. You will find RBCs which have the typical RBCs with a large central pallor in the peripheral smear. All these are the features what you get in investigation. Unconjugated hyperbilirubinemia, a little bit may be seen. Treatment is, ideally, this is transfusion dependent. So we only have to keep giving transfusions if we don't post the child for bone marrow or umbilical stem cell transplant. That is the definitive treatment and cure. Till then, it is only red cell, packed red cell transfusions with chelation therapy. Features of iron overload to be looked for very carefully, especially as iron overloads on the endocrine organs, and it produces delayed puberty, tetany because of accumulation on the parathyroid. Iron accumulates on in the liver, producing cirrhosis, in the cardiac, producing myocardial dysfunction. So chelation is with desferrioxamine. This is the parenteral drug. Deferriprone and deferasirox. These are the two oral iron chelators, and very good chelation is needed if a child is transfusion dependent. Iron deposits in endocrine organs maximally, apart from the reticuloendothelial organs. Slate gray pigmentation of skin is also because of iron deposition under the skin. Why does iron deposit? Because iron is only controlled at the point of absorption. There is no excretory pathway for iron in the body. Okay, so with this, I hope you all have had a crash course through pediatrics and you all ace your pediatrics MCQs in your NEET 26. Wishing you all the very best. Thank you. If there are any questions, can any of you help me with the questions?